We all strive for the good life, the ability to achieve happiness, to become a master of ourselves, and to live a more meaningful and fulfilling life. At eLife, our core purpose is to help you achieve a good life by enhancing, enriching, and empowering you to become a master of yourself. Life is full of rigors and stresses that may damper your ability to perform life's tasks, which is why we've dedicated our entire lives to design supports and braces specifically tailored to restoring mobility and improving our patients' quality of life. As a world leader in medicinal orthopedics, each design is rigorously tested and designed to the highest clinical excellence standards. For the past 20 years, we collaborated with leading clinicians, researchers, and advanced world-class facilities to produce sports braces, orthopedics, and prosthesis. Our progressive designs and commitment to quality, innovation, and product safety ensure that our patients achieve maximum comfortability, optimal performance, functional mobility, and most importantly, long-term peace of mind. With the global outbreak of COVID-19, we've continued to innovate by connecting with our distributors through our virtual trade event. We introduced our latest product innovations in braces, orthosis, and prosthesis, such as the Pressing Band, Q-Fit, Fast, Thermo, and Cool Fit series. As the pandemic continues to put additional strains on hospital resources and medical supplies in many countries, we have an opportunity and an obligation to explore methods of extended, reuse, and recyclability options for medical supplies. With this strategy, we continue our contribution to the healthcare personnel battling COVID-19 by providing an eco-friendly and sustainable solution to the mass shortages of medical devices now and in the future. eLife's competitive advantages consist of our mature R&D, material supply chain, high-end medical equipment, and reputation as a quality-oriented supplier via our international marketing efforts. As an industry-leading corporation in the medical device industry, we have dedicated over 400,000 square feet of our facilities to meet medical devices' increased demands. We employ more than 1,000 workers and continue to work with certified distributors across all 7 continents. With our clinical backing and year-over-year revenue growth, eLife has become a prominent contributor to the world's medical industry. eLife continues to seek partnership with other leading medical companies to expand product offerings to include a wide range of motion sports braces, prosthetics, and orthopedics. Here at eLife, we are all about embracing life, engaging in life, and supporting those who wish to take their athleticism and support to the next level. Together, we can achieve the good life.
Welcome to eLife.
Kada visurunu hituri dia bubure naliana pena keti wage natiwe khuda kalave tani vi hitiya sihina kare ka vetuna wage nimak ne ke vena kalaya danena wakata tek vidihata diniyam mira sanga sisilasa hotare hoyana me api kauruda situam kala atare ahanawa palanawa me api kauda hira basayan gomyame karu ek dek dilisen kalwa kaase kala den ritme nahavi hadiyanne dinyata paavi surang se ohotin mohotata gevena kalaya danena wakata tek vidihata diniyam mira sanga sisilasa watare hoyana me api kauda
Halo யாருங்க
හඳුනාග ආදරේ ගෙවමු අපේ ජීවිතේ
සමන් පුරායින ඔබේ ජීවිතෙන් අදක් පිරියනවා නුවන් පිරිය කඳුළලේ අතරින් සිනා ගලා එනවා
අඳු පෙරයේ සීනනේ ඉන්දියා කෙරේ හඳුනාග ආදරේ ගෙවමු අපේ ජීවිතේ
Sri Lanka, the land of thrill, culture, and natural beauty. Be it the charm of its endless beaches, rainforested peaks, or over 2,000-year-old culture riding on timeless ruins, Sri Lanka's picturesque landscape is right out of a canvas. Still unperturbed by the footprints of tourists, the island country rests between the Indian subcontinent and the rest of Southeast Asia. Described as the best island of its size in the world by Italian explorer Marco Polo, Sri Lanka is one of the most sought-after destinations for solo travelers, culture seekers, families, and wildlife enthusiasts alike. Here are the experiences that await your arrival in Sri Lanka. For solo travelers, if your heart goes out to palm-fringed beaches that entertain endless strolls under a sun-kissed or starry sky, then Sri Lanka is the place for you through dusk and dawn. For culture seekers, experience Sri Lankan life by biking through its plantations, exploring farmers' markets, local temples, and ruins, and trying your hand at traditional stilt fishing. When you're done, call it a day with the popular Sri Lankan Ayurvedic treatment. For wildlife lovers, gear up to drive into the heart of wildlife that is bound to give you goosebumps. Witness the island's iconic wild elephants appearing out of nowhere and mighty blue whales crashing into the water right in front of your eyes. Reaching Sri Lanka. Sri Lanka to convert INR to is blessed with a tropical climate. The country entertains two separate monsoon seasons, which keep the weather quite pleasant throughout the year. However, if you're heading to the west coast, the best time to visit is from December to April. And those visiting the east coast, April to August is the best time to go. If you are really fond of rain, then don't miss out on visiting around the inter-monsoon season between July to September. Where to go? Yala National Park. Grassy plains, salty lagoons, mild forests, wild animals. That's what makes Yala National Park, the second largest national park of Sri Lanka, the most visited place. Scoop out some time for the safari and witness how the jungle prides itself on being home to wild elephants, crocodiles, leopards, wild boars, and all its citizens that keep the thrill high. Sigiriya. Sigiriya is one of the most important historical monuments of Sri Lanka. The ancient palace is also considered as the eighth wonder of the world by the locals. While its rocky outcrop makes it the most dramatic sight, the ruins of an ancient civilization on the summit make it a more tempting mystery. Once you come here, you will experience how nature, art, and ancient urban planning have been maintaining harmony for ages. Tuna. The most popular beach town in Sri Lanka, Tuna is every traveler's favorite. The town is high on nightlife, culture, and local lifestyle. Here, you can chill at fancy restaurants and hipster cafes or enjoy a quiet swim while embracing the beauty of the ocean. And if you feel like being more adventurous, just snorkel your way around the coral reefs. Dunhinda Falls. Dunhinda Falls is one of the most beautiful waterfalls in Sri Lanka. It is known as the Bridal Fall because when the water plummets 210 feet down, it appears just like a bridal veil, a beauty worth witnessing. This dazzling waterfall gushes in the lower central hills of the country, and it turns more thunderous over the months of November to March when heavy rain hits the island. Accommodation. From high-end hotels and luxury stays to rural lodges, homestays and hostels, Sri Lanka has something for every kind of traveler. What to eat? Sri Lanka is a typical foodie paradise. While fish and seafood rule the menu, coconut flavor sways in the majority of dishes. The authentic flavors will make one gobble up any cuisine to their heart's content. If you enjoyed this video, hit the like button. Don't forget to share your travel stories and tips in the comment section below and share the video with someone you want to travel with. Subscribe to Tripoto and keep fueling your wanderlust.
We all strive for the good life, the ability to achieve happiness, to become a master of ourselves, and to live a more meaningful and fulfilling life. At eLife, our core purpose is to help you achieve a good life by enhancing, enriching, and empowering you to become a master of yourself. Life is full of rigors and stresses that may damper your ability to perform life's tasks. which is why we've dedicated our entire lives to design supports and braces specifically tailored to restoring mobility and improving our patients' quality of life. As a world leader in medicinal orthopedics, each design is rigorously tested and designed to the highest clinical excellence standards. For the past 20 years, we collaborated with leading clinicians, researchers, and advanced world-class facilities to produce sports braces, orthopedics, and prosthesis. Our progressive designs and commitment to quality, innovation, and product safety ensure that our patients achieve maximum comfortability, optimal performance, functional mobility, and most importantly, long-term peace of mind. With the global outbreak of COVID-19, we've continued to innovate by connecting with our distributors through our virtual trade event. We introduced our latest product innovations in braces, orthosis, and prosthesis, such as the pressing band, Q-Fit, Fast, Thermo, and Cool Fit series. As the pandemic continues to put additional strains on hospital resources and medical supplies in many countries, we have an opportunity and an obligation to explore methods of extended, reuse, and recyclability options for medical supplies. With this strategy, we continue our contribution to the healthcare personnel battling COVID-19 by providing an eco-friendly and sustainable solution to the mass shortages of medical devices now and in the future. eLife's competitive advantages consist of our mature R&D, material supply chain, high-end medical equipment, and reputation as a quality-oriented supplier via our international marketing efforts. As an industry-leading corporation in the medical device industry, we have dedicated over 400,000 square feet of our facilities to meet medical devices' increased demands. We employ more than 1,000 workers and continue to work with certified distributors across all 7 continents. With our clinical backing and year-over-year revenue growth, eLife has become a prominent contributor to the world's medical industry. eLife continues to seek partnership with other leading medical companies to expand product offerings to include a wide range of motion sports braces, prosthetics, and orthopedics. Here at eLife, we are all about embracing life, engaging in life, and supporting those who wish to take their athleticism and support to the next level. Together, we can achieve the good life.
Welcome to eLife.
Good evening, everyone. Thank you for joining from all over the world to celebrate World Physiotherapy Day with the Sri Lanka Society of Physiotherapy. I'm Priyanka Nanaikarawasa, Council Member of the Sri Lanka Society of Physiotherapy, speaking from Sri Javadanapura, the capital city of Sri Lanka. This year's World Physiotherapy Day theme declared by World Physiotherapy, the global organization for physiotherapists, was osteoarthritis and the role of physiotherapists. Therefore, the Society as a member of the World Physiotherapy selected the topic Current Interventions in the Physiotherapy Management of Knee Osteoarthritis for the free international webinar. In this seminar, 2 guest speakers and 6 experts will talk to you. We are grateful to all the experts who volunteered to share their knowledge and experience with us. If I brief the agenda of today's session, the President of the Sri Lanka Society of Physiotherapy will welcome the audience first. Then the guest speakers will deliver their speeches. After that, The expert lecturers will talk to you about the current interventions and physiotherapy management of knee osteoarthritis. We hope to conclude the session at about 11:30 p.m. Sri Lankan time. Before we start the session, there are few messages to be conveyed. This webinar recording will be available to you, but it will take few days. Participants who stay throughout the session will receive an electronic certificate. They will receive a confirmation email within a week. The lecturers will give you time at the end of each session to ask questions. You can ask if you are having any questions in that time. Another important thing is that we could make this webinar free to all of you because of our sponsor, eLife Orthopedic Products of CIC Health and Personal Care. To start the session, I cordially invite the President of the Sri Lanka Society of Physiotherapy to welcome the audience.
My dear colleagues, distinguished guests, international clinical expert presenters, and friends, to mark the year 2022 World Physiotherapy Day, Sri Lanka Society of Physiotherapy Executive Committee has decided to launch an educational webinar today. This year, physiotherapists in Sri Lanka are proudly year in physiotherapy education, started in 1951, and also the 36th anniversary of Sri Lanka Society of Physiotherapy, founded in 1986. On behalf of all the physiotherapists in Sri Lanka, as the current president of the society, it gives me a great pleasure to welcome our distinguished guests, the Chief Executive Officer of World Physiotherapy, Mr. Jonathan Kruger, the Director General of Health Services, Sri Lanka, Dr. Asela Gunawardena, and thank you all, those who are participating from Sri Lanka and overseas. I take this opportunity to warmly welcome and thank our clinical expert presenters, Dr. Swarna Kumar, the Senior Consultant Orthopedic Surgeon of National Hospital, Sri Lanka, Assistant Professor S.M. Mustafa Kamal of SAIC College of Medical Science and Technology, Bangladesh, Dr. Rasanga Lakmal Gunawardena, Consultant Orthopedic Surgeon and the Senior Lecturer of the Department of Surgery, Faculty of Medicine of University of Ruhuna, Sri Lanka, Dr. Jayamin H. Bhatt, Specialist Physiotherapist in Kinetic Control Manual Therapy in India, Professor Dr. Manish Arora, Dean of SBS University, Balabala, India, Senior Specialist Physiotherapist P. Bhaskar Reddy, Ministry of Health and King Khalid Hospital, Najran, Saudi Arabia, who kindly accepted our invitation to conduct valuable lectures to share and impart their knowledge, experience, and skill. One of the apparent triumphs of last 3 decades was the evidence-based safe practice, which is well established in the developed countries after enormous amount of clinical research done pertaining to the clinical interventions performed for safe delivery of patient care with confidence and competence. World Physiotherapy, the International Confederation, has announced earlier to its member organizations that this year's focus for the World Physiotherapy Day is osteoarthritis and the role of the physiotherapists in its prevention and management of people affected by osteoarthritis. Our international education program organizer of the Executive Committee of the Society, Mr. Vasanta Kumara Senanayaka's selection theme was ultrasound-guided autologous PRP injection therapy for osteoarthritis. as well as the surgical and physiotherapy management, which was approved by the committee. As a chartered physiotherapist in the UK, I had gained a fair knowledge and experience, as UK physios have got the prescription and injection rights, and they are commonly practicing with the ultrasound-guided autologous PRP and stem cell injections on sports injuries for an early recovery to prevent fibrous tissue formation. In future, I hope our Sri Lankan physiotherapists would be able to practice these advanced treatment modes as international physiotherapists with the necessary legislation. I believe it is rewarding experience and excellent new knowledge you could gain out of these lecture topics, which were suitably selected to improve continuous professional development and help lifelong learning. I strongly believe that the contents of the lectures would be beneficial to all the physiotherapists practicing in the fields of musculoskeletal, neuro, orthopedic, and sports to enhance their knowledge and technical skills, which is vital for the achieving greater heights in their career, and to those who are interested in becoming an autonomous practitioner who could deliver services with confidence and competence. As you all aware, our organizing chair, Mr. Vasanta Kumar Siranayaka, made an unimaginable contribution and commitment to make this international webinar a success. And with the ardent support from the organizing committee, comprised of Society Treasurer, Honorable Mrs. Priyanka Nanayakaravasam, Mr. M. Rajkaran, and Mr. Samantha Kumara, and special thanks for Honorable Vice President, Mr. Dhammika, and Honorary Secretary, Mr. Rasika L. Jayakodi. Dear colleagues, please make sure that after the sessions to forward your questions to relevant expert lecturers, but not to me, as I have no clue about those subject topics other than a little in cardiorespiratory critical care.
Thank you, Mr. Malavira, for the speech and for the strength that you are giving us. Our first guest speaker today is Mr. Jonathan Kruger, Chief Executive Officer of World Physiotherapy. Mr. Kruger is an Australian qualified physiotherapist with qualifications in public health, law and governance. He commenced his duties at World Physiotherapy in 2016. It is time for Mr. Jonathan Kruger, CEO of World Physiotherapy.
Thank you very much to the Sri Lanka Society of Physiotherapy for the kind invitation to give this short guest introduction to your webinar today on the occasion of World Physiotherapy Day in 2022. My name is Jonathan Kruger and I'm the Chief Executive Officer of World Physiotherapy. For those of you who are less familiar with World Physiotherapy, we are the global membership organisation for the physiotherapy community, and we represent 125 member organisations from all the corners around the globe. Our purpose is to represent physiotherapy, to advance our profession and to advocate for access to our services for all people. This will help us to achieve our vision, which is that everybody has universal access to quality physiotherapy services where and when they are needed. A bit more about World Physiotherapy. Currently, we represent 685,000 physiotherapists across the globe, and that's about 60% of the estimated 1.9 million physiotherapists that are currently are working around the world. As you can see from this map, the darker areas are where there is a lot more physiotherapists, and the grey and the lighter blue areas are where there is less physiotherapists. So the distribution of physiotherapists around the globe is not even. In Sri Lanka, the Society has about 360 members out of the estimated 600 physiotherapists within the country. Within the region, there are about 227,000 physiotherapists that are part of their local organisation, out of the estimated 415,000 physiotherapists that are currently in the Asia Western Pacific region. When we look at gender, within the Sri Lankan Society, 53% of the physiotherapists are female, and that compares to 50% in the Asia Western Pacific region. But it is considerably less than the percentage of females globally, which currently stands at about 59 to 62% of physiotherapists in any country around the world are female. What about the number of practicing physiotherapists in Sri Lanka? At the moment, there are 0.28 physiotherapists per 10,000 population in Sri Lanka. So with a population of 22 million in Sri Lanka, to reach the average, which is 1.59 per 10,000, Sri Lanka would need to have 3,300 physiotherapists. So there is an opportunity in Sri Lanka for there to be more physiotherapists if you want to reach the average that exists within the Asian region. But this would take a lot more training of physiotherapists to achieve that goal. The way in which the goal will be achieved, though, is to have a strong national physiotherapy association. And so if you are not a member of the Sri Lankan Society of Physiotherapy, then I would encourage you to join. If you are a member of the association, then I would encourage you to be as active as possible, because the more that you contribute to your local member association, the stronger physiotherapy will be in your country. So as I said, this webinar is being held to celebrate World Physiotherapy Day, which is held every year on the 8th of September. And this year the focus is going to be on osteoarthritis. And I can see from the program there is a range of fantastic speakers who are going to speak on this topic today. So I hope you all have a fantastic webinar, and there is much that you find to learn within the content today. This webinar is being held online, obviously, and that's great that we can do that. But what is also really great is when we come together as a profession. And so I would like to invite you all to come to meet with me in Dubai next year on the occasion of the World Physiotherapy Congress in 2023. It is being held from the 2nd to the 4th of June, and the program that is being developed currently is shaping up really well, and I'm sure there's going to be, again, lots of opportunities for learning and professional development that will occur there if you attend. So please, you're very welcome to attend, and I would love to see you there. So that's it for me for today. So good luck with the rest of your webinar, and I look forward to hearing about how it all goes. So take care and see you soon.
Thank you, Mr. Kruger, for the compliments. Our next guest speaker is Dr. Asela Gunawardena. Dr. Gunawardena is the Director General of Health Services in the Ministry of Health, Sri Lanka. He's a medical graduate from the University of Peradeniya and obtained a degree in business administration from the Open University of Sri Lanka. He took office at the Ministry of Health in October 2020. Dr. Azela Gunawardena, Director General of Health Services, will speak a few words to you.
Distinguished guests, ladies and gentlemen, today marks the World Physiotherapy Day. This day was founded in 1951 and September 8th of each year was designated in 1996. This day characterized the unity and the solidarity of the global physiotherapy community. Also, this gives us an inevitable opportunity to recognize the work that physiotherapists do for their patients and community. Activities aimed at the program this day will not only support physiotherapists around the world in their efforts to promote profession but also advance their expertise. This year's focus on World Physiotherapy Day has been announced as Osteoarthritis, a global problem. Osteoarthritis is the most common joint condition. 520 million people around the world have osteoarthritis and 60% of osteoarthritic cases are knee osteoarthritis. This is the 11th contributor for disability out of 295 conditions in a global study. Hence, this topic is the most suitable at this point of time. Physiotherapy, including exercises, is a first-line treatment for osteoarthritis. A physiotherapist can make an individual plan for exercise to keep the patient mobile and manage symptoms with osteoarthritis. Moreover, he or she can advise and educate about pain relief with ways to manage osteoarthritis. They can train people living with osteoarthritis on how to improve their quality of life. It is very important to keep patients living with osteoarthritis as active as possible. This can help improve pain, reduce other symptoms of osteoarthritis, and help people stay independent. Therefore, your role is big and wide to combat the disease. I take this opportunity to congratulate physiotherapists around the world on this special day and have a fruitful session. Thank you.
Thank you, Dr. Gunawardena, for speaking to us on this great occasion. Now we will move on to our theme lectures. The first lecture, platelets-rich plasma or PRP in the treatment of knee osteoarthritis, is delivered by Dr. V. Swanakumar. Dr. Swanakumar is the Senior Consultant Orthopedic Surgeon at the National Hospital of Sri Lanka, which is the main government hospital providing free health services to the nation. He obtained his medical degree from the University of Jaffna and his master's in surgery from the Postgraduate Institute of Medicine, Colombo, Sri Lanka. He is a fellow of the Royal College of Surgeons, Edinburgh, Scotland. Now please welcome Dr. V. Swanakumar, Senior Consultant Orthopedic Surgeon.
Good evening, everybody. Hope you can hear me. First, I would like to thank Physiotherapist Organization in Sri Lanka for inviting me and sharing my experience in orthopedics practice of usage of platelet PRP. And as our Director of Health Services addressed, osteoarthritis is a common problem worldwide, and we have to spend a lot of money in managing these patients with osteoarthritis worldwide. In Sri Lanka, we have been managing with non-operative management, and it is partly done by the physiotherapists. They play a major role in managing them before considering any surgical management, or even after surgical management. You all have a main role, and you have been one of the pillars in supporting orthopedic surgeons, not only in Sri Lanka, worldwide. So again, I would convey my message to all for successful international meeting this time. And again, I would like to thank you for inviting me in this great occasion. The platelet-rich PRP in orthopedic practice, just I would say, and again, I will focus mainly in the management of osteoarthritis. So what is PRP? Everyone, you know that platelets, they have a great number in the blood, 150,000 to 450,000. And they have the diameter of 2 to 4 micrometer in diameter. And they have a 7 days of half-life. And they are alpha and dense granules. And they contains so much of growth factors. Because of that, we have selected the platelet for the treatment of healing wounds, as well as in the management of osteoarthritis. So what is PRP? This is the autologous blood taken from the patient, and it has the count and the significant count, as I told before. And in the PRP, that is after centrifuging and getting the number, it gives 5 times the normal count of platelet in the concentrate. Platelet-rich plasma is injected, and it is popular worldwide, and also it is used in variety of conditions, sports injury to hair loss. The treatment and the platelets with the growth factors concentrated in it, it has the healing effect. Therefore, PRP has a major role nowadays in the management of many conditions. So main functions of the platelets, if we can consider, it has hemostasis. As you all know, this has the first role in the management of bleeding. So it forms a platelet plug. It helps in blood clot formation. And there are so many secretions, including growth factors. It promotes cellular chemotaxis and proliferation and differentiation of cells. And it also helps in proliferation of human adults, MAC, that's a PDGF. Proliferation of fibroblasts. Fibroblasts, you all know, it is important in the wound healing and also in inflammation, part of the inflammation. And angiogenesis, that means it helps to revascularization of the tissue when there is damage. Regeneration of appropriate tissue. That's why we use in wound healing, and also in practice we use in fraction on union also, because it helps to regenerate the tissue. So biomaterial should follow when we select this PRP. Why it is selected? Because it should enhance tissue repair to a clinically significant degree. It should not lead to a scar formation. When we are giving something, if it causes scar formation, then it is not recommended. So it provide minimal risk to the patient. It should act only locally, but not systemically. It has to be cost effective, especially in our setup like Sri Lanka. It has to be easy to apply. So that's the property of a material when we select for you. When we talk about actions of PRP, it accelerates endothelial, epithelial, and epidermal regeneration. It stimulates angiogenesis, enhances collagen formation, promotes soft tissue healing. Therefore, it helps in wound healing as well as repair of tissue after surgery. So it has a major role in post-operative patients. Enhances hemostatic response to the injury and reverse inhibition of wound healing caused by glucocorticoids. As you all know, when we give glucocorticoids, it reduces the wound healing, but with PRP, it reverses the action of glucocorticoids. So why PRP is selected? It has so many growth factors it contains. So these growth factors are released when the platelet is injected. So for example, FGF, that's a fibroblast growth factor. It helps in tissue repair. Epidermal growth factor, it helps in epithelial cell growth and also angiogenesis. Keratinocyte growth factor, it helps in degeneration of keratinocytes. TGFB, that's a transforming growth factor. It helps for endothelial transformation. VEGF, vascular endothelial growth factor. So it helps in vascular endothelial cell regeneration. PDGF, that's a platelet-derived growth factor. So it helps for cell growth, new generation, and repair of blood vessels. So many factors are there in the normal count, and also when it is concentrated, it gives better effect because of these growth factors. So considering all these factors from the platelets, that's the growth factors, inflammatory mediators, and it contains fibrinogen. Fibrinogen, it acts as a scaffolding effect and anti-inflammatory effect from the inflammatory mediators, and also growth factors, it has anabolic effect. So considering all these three factors, the properties of these platelets we are using in platelet-rich plasma. So when you take this platelet-rich plasma, there's a PRP, there are two types. When we, after concentrating this one, it contains leukocyte poor plasma, that is LP. It is used in osteoarthritis, acute muscle injury, and also in tendon repair. But leukocyte rich plasma, it is well used in tendinopathies. So when we use this platelet plasma, I will tell how it is prepared in the next slide. So there's a classification we use for platelet concentration that's compared to baseline concentration in the whole blood. It is high, and activation method, that's endogenous, exogenous methods. It contains thrombin, collagen, and calcium, and white blood cells are used. So all three are used for classification of this PRP. So how do we prepare this PRP? Usually we draw about 3 to 60 ml of blood from patients, and it is centrifuged for 15 minutes at the rate Once we centrifuge this blood, the picture shows the red blood cells in sediments at the bottom, next white cells, and above the white cells, we can see the platelets. And on top of that, the plasma. So the plasma in the upper part, it contains less platelets, but the plasma layer next to white blood cells, it contains concentrated platelets. So that part only we use for treatment using this PRP. So we take about 3 to 6 ml of PRP. It is 4 to 10 times concentrated than the normal platelet count. Sodium bicarbonate used to neutralize the activity of this sample. So after using this is used. So this is the way the blood is taken from the patient and it is centrifuged. After centrifuging, we can see the platelet rich plasma. There's a PRP fraction 1 that's in the top layer. It contains less platelets. That's what is called PPP. That is platelet poor plasma. And fraction 2, that is the layer just above the white cell count, is called PRP. There is a platelet rich plasma. So that upper part of this plasma is removed, and the plasma above the layer of white cells, it is taken and injected to the region for the better outcome of these patients. So factors affecting action of PRP on tissue healing, because PRP has to work on the tissue healing, and there should be the favorable environment for the platelet to activate. There are endogenous and exogenous activations are there. When the platelet concentration is 1 to 5 times fold, it has more action than when it is more than 10 times fold. That's why we take only 50 to 60 ml of blood to take the appropriate concentration of the plasma. And volume of PRP. So when we give, it has to contain reasonable volume of PRP. So then the activation will be better. And it has to contain relative concentration of WBC. That's what I told you for the healing of the wound or tendinopathies. The platelet containing WBC has a better role in the management. So what are the orthopedic applications of PRP? Mainly for non-surgical conditions, non-surgically managed conditions, medial and lateral epicondylitis, plantar fasciitis, patellar tendinopathy, and osteoarthritis of knee. Surgical interventions after Achilles tendon repair or any other tendon repairs, mainly rotator cuff repair. After ACL reconstruction, when we use PRP, it gives better outcome in the management of incorporation of the graft with the bone, and also it promotes healing of the repair. It has advantages because it's an autologous product. We take from the same patient and we separate the autologous. So it is done as an outpatient procedure. We don't want to admit the patient. They come and do the procedure and can go home. There are very minimal complications, less chance of infection. We use it under sterile condition, and there's less rejection because it's a own patient's product. There's an autologous product, so there's less chance of rejection, and there are no systemic effects, and it's readily available. We don't want to prepare additionally. The patient, when he comes, we take the blood and prepare it and inject. Less long-term complications. Long-term complications are not reported commonly. Clinical examples, when we take partial tear of supraspinatus tendon, we use supraspinatus tendon. It is a deeper structure, not like epicondylitis. This is a bit deeper. And if we can use ultrasound, that's ultrasound guided injection, then we can inject to the area there. And even other places like the picture shows there's a injection of the elbow for lateral epicondylitis. So the same way, when we use the ultrasound guidance, we can exactly localize the place where we have to inject it, and we can inject. Platelet acts as a scaffolding for mesenchymal stem cells, which starts the process of tissue regeneration. So it is a better scaffolding effect when we are using. After injection, it has no discomfort, but some patients, they have minimal discomfort for about a week. They may have the pain at the local site after the injection. Because anti-inflammatory drugs, they have the antiplatelet function. For example, aspirin and other NSAIDs, they are used in patients with to delay blood clotting. So if we can avoid usage of anti-inflammatory drugs, that'll be better during this period. So it is recommended to avoid anti-inflammatory medications for 6 weeks. So other condition we use is lateral epicondylitis. The PRP treatment is a treatment of choice. And there are high quality of evidence shows it's a short-term and long-term efficacy is good after epicondylitis. Long-term follow-up results showed significantly less pain than control group in a research study. Patellar tendinopathy, when this PRP is used as multiple injections, it showed best results at long-term follow-up more than 6 months. So the PRP injection can be repeated. So this is one of the examples when we use for long-term, it gives a better results. Achilles tendinopathy, where it is not indicated for conservative management, because conservative management is when there is a Achilles tendon rupture. If the patient is not willing for surgery and when there is a gap in between the tendon, we can't use, there's no place of using PRP. It is not going to help in regenerating tendon completely, but it is recommended after repair of Achilles tendon, if we it promotes healing and well incorporation of ruptured fibers and give better healing and good outcome after PRP injections. Rotator cuff tendinopathy, again, as I told you before, in the shoulder injuries, one of the common injuries, rotator cuff tendinopathy, is done by arthroscopic procedures. After arthroscopic procedures, when we give injections, it helps in good healing. The healing rate is good and pain level and functional outcome is good with less pain. PRP reduces retear. That is, after repair, if PRP is given, chance of tear again is less. And for medium size and small size, even without surgery, when PRP is given, the healing takes place in a better way. So that is recommended for partial tear, PRP can be given. Plantar fasciitis, there were 3 articles. It shows, all studies shows greater symptomatic improvement in plantar fasciitis. Improves pain and functional scores compared to steroid injections. So when you compare the steroid injection, it's a better outcome. But in the long term, there's no difference between the PRP or without PRP injection. But it is superior to steroid injections, considering the complications and of multiple corticosteroid injections. PRP is superior than steroid injections in plantar fasciitis. So what's the rehabilitation following PRP in tendinopathies? We have to avoid NSAIDs, avoid smoking, because smoking, it inhibits platelet functions. So therefore, avoiding smoking is better. Weight bearing, it is recommended not to non-weight bearing for 3 days and gradual weight bearing after 4 days. And eccentric exercises after 6 weeks can be started in patients after tendinopathies. Osteoarthritis, as you all know, it's an articular cartilage, is frequently exposed to multiple micro or micro traumatic events that may lead to loss of tissue homeostasis, resulting in the acceleration of loss of articular cartilage and progression to arthritis. So it is a progressive condition. It starts with age. The cartilage undergo degenerative changes. Because of that, osteoarthritis develop. Inherently, the poor regenerative capacity of the cartilage continues to make the articulate cartilage disease, and it's a challenging problem for orthopedics. So majority of patients with osteoarthritis, they are managed non-operatively. So in these patients, physiotherapy, pain management, and PRP, it has an important role in the management. Only certain group only we select for surgery. So in osteoarthritis, growth factors in these platelets, it increases the synthetic capacity through upregulation of gene expression, proteoglycan production, and deposition of collagen. It helps in maintaining the cartilage function without degenerating further. So PRP, its clinically significant function improved the better scoring system in 1 year. As I said before, it's only useful in mild to moderate osteoarthritis only. Well-established osteoarthritis, when there is bone-to-bone contact, or if the patients are recommended for surgery, some patients, they don't agree for surgery. In those well-established osteoarthritis, PRP is not going to work. It may give mild pain relief for short period, but it is recommended only in the early stage of osteoarthritis. There's a research in Japanese population they have done, and they selected a patient with osteoarthritis of knee, and they injected in weekly interval PRP injection, and they found the symptom disappeared within 48 hours. So this therapy has potential to reduce the pain relief, and this is maintained for up to 6 months. But there are further studies needed. So these are Japanese studies published in 2018. So in use of PRP in osteoarthritis of knee, the early studies indicate that PRP injection may help to treat osteoarthritis, pain, and stiffness by modulating the joint environment and reducing the inflammation. But still, researchers are going on. There is no definite proving, but there are patients' evidence, even researchers promising better outcome in osteoarthritis of knee in early stage. So there are certain questions I have to answer. Does PRP help in ONE? So as I told you before, only in mild to moderate osteoarthritis. Participants who received platelet-rich plasma injections had a significant improvement in their knee pain over 12 months. In another research article, it says. So there is evidence, but still researchers are going on. Another question, another myth, can PRP reverse osteoarthritis? The patients come and ask from us whether the PRP will bring the osteoarthritis back to normal. No, it's not going to happen, because it's not going to form the new cartilage and bring the arthritis back to normal, but it preserves the cartilage that already you have left behind within the knee. And it improves the quality of life and may enable you to put off further consideration of surgery as an alternative treatment. So you can delay the surgery, or temporarily you can have the pain relief and not to come back to normal. So PRP injections have not been shown to reverse or cure the arthritis. That's my answer. How long the injection lasts when we give for osteoarthritis? There have been studies done to suggest the PRP injections can be effective for 6 to 9 months. Repeated injections can be given in the interval according to the patient's symptoms. So in 6 to 9 months interval, the injections can be repeated. I am telling again, it's only in the mild to moderate arthritis. Or if the patients, sometimes then they may be having many comorbidities and they are not recommended for surgery. So when the risk is high, so there are patients, they request PRP, so they have some pain relief. It is better than giving steroid injections. Another questions, does PRP regenerate meniscus? When there is meniscus removed by surgery, or when there's complete tear and it is partially removed, it won't regenerate the meniscus back to normal. But when there's a partial damage or partial injury to the meniscus, if PRP is given, it can stimulate the healing. Or if the meniscal repair is done, after meniscal repair, if you are giving PRP injection, it will facilitate the healing of torn meniscus. So it is recommended after meniscal repair, or when there's a partial tear of the meniscus, that will help for the patient to improve the pain. It is evidence, but it's not going to bring the meniscus back to normal. So another question, how frequency of the PRP to be given? Up to 3 PRP injections within a period of 6 months period, usually performed 2 to 3 weeks apart. So it is usually recommended to give in 2 weeks interval 3 injections as a course, and it can be repeated after 6 to 9 months whenever the patients are needed for pain relief or to postpone the surgery or anything. So it has been used in patients after ACL reconstruction. When there's an ACL complete tear, the PRP is not going to help to regenerate or repair the ACL. But ACL, when it is torn, surgery is indicated in selected patients after surgical intervention. And if PRP is given, there should be osteoligamentous integration, but we are reconstructing the ACL using autologous graft by making tunnel in the tibia and femoral area. So when we give PRP, it helps to incorporate the graft with the bone. So there is osteoligamentous integration takes place in these patients. Maturation of articular portion of the graft. It helps to mature the graft early. And there is evidence that graft harvest site healing and pain reduction is noticed in these patients. There are new studies, it shows decreased donor site pain after ACL reconstruction. We use in fraction non-union. So in patients with fracture and when there's non-union, this atrophic non-union, when there's no evidence of fracture union. So we use injecting platelet-rich plasma to the site under the X-ray guidance or ultrasound guidance. It helps in promoting fracture healing because it is an inflammatory process. After the fracture, the healing is an inflammatory process. So when we inject platelet-rich plasma, it helps to promote healing. So it is used in management of non-union. What are the risks of platelet PRP? So it is very minimal. When we inject, it may cause bleeding at the site of injection, but usually it is painful for a few days, and after that it will settle gradually. And it can cause infection very rarely, but still we use under a sterile condition. So it is not common. Pain at the site of injection, yes, it is there for the pain. So we can give analgesics, not anti-inflammatory, but we can give analgesics for the patients after injections. And local tissue injuries can happen when it is given without the guidance of ultrasound. So there's a chance in certain areas when we inject, it can cause muscle damage or even nerve injuries have been notified when it's given by inexperienced people. So in summary, PRP has been used as treatment of modality in many conditions in orthopedic practice. It's a less invasive procedure. Reasonable patients' satisfaction have been notified, and research says it has a better outcome, especially even in osteoarthritis. And it is a cost-effective procedure, but there are more research going on, and they need some more confirmation to use in these patients with osteoarthritis. Thank you very much. And I am thankful to the organizing committee, especially Mr. Kumara, the physiotherapist who worked with me in Karapitia, and still he is doing a better service there. He's the one he promoted me to deliver these lectures. Thank you, Kumara, and all participants, and wish you all the best for the successful day, and wish you all the best. Thank you.
Thank you very much, sir. It's very informative. Sir, there are a few questions. Shall I read it, sir?
Yes.
The first question is, if the patient is having blood disorders like sickle cell anemia, would PRP work?
Yes, even with sickle cell anemia, it's a different condition, but PRP, if the platelet count is normal, it can be used, because sickle cell anemia is a different condition, but it is not a platelet related disease. So still it can work.
Thank you, sir. The next question is, what are the conditions when PRP is not performed?
PRP is not performed. The two examples I told you, when there is a tendon rupture, complete rupture, and where there is a surgery is indicated, because tendon, when there is a rupture, we have to bring together and repair it. Without repairing, using a PRP is not going to regenerate or build up the tendon there. And other conditions, like well-established conditions like osteoarthritis, where surgery is indicated, it's not going to help. So usually I don't recommend these patients, even when they come and ask for PRP in well-established osteoarthritis, they need surgery. I don't want to give injections.
Okay, sir. The next question is, sir, what are the contraindications for PRP therapy?
Contraindications, if they have disease related to platelets, for example, if it's a thrombocytopenia, right? So there are conditions related to platelet disease, platelet dysfunction. So those conditions we have to avoid. If the platelet count is not adequate, then we have to get an opinion from the hematologist, and then we have to plan. Only that's a condition. Other contraindication is when there is any local wound or any skin reactions. We don't give PRP because it can promote infection. It can bring the infection from the skin to the local site. So that's a contraindication. When there's a local wound or any skin allergic reactions around the area where we are going to inject, it is contraindicated.
The next question is, how effective is PRP for union in post-op fracture, shaft humerus with bone graft?
Yes, it is indicated for in patients with a poor healing tendency. When we, for example, if there's a non-union, we have operated and the patient is applied bone graft at the time of surgery. So in addition, we can give PRP. Even stem cells we inject to promote bone healing in those conditions. Not all patients. Some patients, they have the good tendency to heal, so we don't want to give. But if there are revision fractures, so for example, if they are fractured and there's non-union in the revision surgery with bone graft, so we can give PRP. We give, that's recommended, and sometimes we use stem cells as well.
Okay, so the next question is, how we as a physiotherapist learn about procedures and how much it will cost us for injection?
Injections for it is the kits, the PRP kits are expensive. Even nowadays, it is very earlier. I can remember about 6 months ago, it was in certain hospitals, it was about 19,500. Now it has gone double the prices for that. So that's only limiting factor. If they want to go for about 3 injections, it will cost a lot for patients.
The next question is, sir, what is the role of physiotherapist after PRP therapy?
Physiotherapy after PRP, I feel that only range of movement exercises, guided exercises can be started after about a week, not immediately. And muscle strengthening exercises and range of movement exercises are recommended. I am not sure about other procedures like shortwave diathermy and everything. I'm not sure about it. That you will have to give me the answer.
Okay, sir.
Right.
The next question is, sir, does PRP still effective even the patient having seborrheic dermatitis in scalp for the hair growth?
In that part, I have less knowledge about hair growth and PRP, because it has to be answered by a person from cosmetic side. I am not an expert, so I am not able to give a definite answer for that.
So next question is, if patient have both gout and osteoarthritis, how PRP can help to that patient?
Can you repeat the question? Both?
If the patient have both gout and osteoarthritis, gout.
Gout and osteoarthritis with PRP, yes, there's no contraindication. We can give, because early stage of osteoarthritis, if it is not well established, we can give PRP. That will give pain relief as well as it promotes healing.
Okay, sir. The next question is, sir, which stage of osteoarthritis will benefit PRP?
Yes, as I told in my previous, during my talk, it's only early osteoarthritis. Only it will develop, but well-established osteoarthritis is not going to be benefited after PRP injections. Only it may give some pain relief for a short period.
Yeah. So the next question is, sir, is PRP useful for rheumatoid arthritis?
Again, yes, in the early stage, but the thing is they use anti-inflammatory drugs. So these patients with anti-inflammatory drugs, when we are using PRP, it's not going to work well. So usually I don't recommend for those patients, those who are in anti-inflammatory drugs, because it inhibits the function of the platelets and also the growth factors, everything is not going to work well. That's my personal experience, but I am not Sure, I am not 100% sure.
Okay. So the next question is PRP contributing to cartilage healing?
Cartilage healing, yes, after cartilage repair, early stage, minor degree injuries, it will be helpful. And in certain conditions, when there's a cartilage loss, we replant with chondrocytes, or even we go for microfractures. After that, we give PRP because that will help to regenerate cartilage for some extent.
Okay. So the next question is, sir, will PRP works in arthritis for a long time? But I think you had answered it before.
Yes, I have answered before. It's only for 6 to 9 months only. Yes.
And the next question is, sir, how much percentage of PRP should be given to the patient?
Usually, the PRP kit, depending on the site where we are injecting. If it is knee joint, we can give about 5 ml. For example, if it is epicondylitis, we can give only a 0.5 to 1 ml because it cannot accommodate more PRP. So we have to take a concentrated one and take only about 0.5 to 1 cc for the epicondylitis. Otherwise, it will be very painful. And depending on the site, knee joint, we can give even 10 ml, no matter.
Okay. So the other question is, so is every graft patient need PRP or only for the patient pain indication? Sorry. Every graft patient need PRP or only for the pain indication?
Only indicated patients, not for all patients. That those who have pain and they are not recommended for surgery. Early osteoarthritis, they have pain, and with supportive method like physiotherapy to improve the muscle functions and range of movement, when we give PRP, they have a beneficial effects.
Okay, so the other question is mild or a mild to moderate OA is according to KL classification?
Yes, it is indicated.
Okay, right. So is PRP effective in adhesive? Okay. Is PRP effective in adhesive capsulitis and first and shoulder both?
Yes, adhesive capsulitis, it has an effect for some extent, but outcome is not as promising as for other tendinopathies.
Okay, sir. Those are the questions, sir. Thank you very much, sir. It's very informative. Thank you very much, sir.
Thank you, Dr. Kumar, for the informative lecture. We just enhanced our knowledge of PRP therapy.
Thank you. Thank you again. Have a nice day and good evening for everyone for enjoying these lectures. I hope it has given some information for you.
Okay, thank you so much.
Thank you.
Our second lecture is about physiotherapy management in post-platelet-rich plasma for knee osteoarthritis. Assistant Professor Dr. S.M. Mustafa Kamal will talk about it. Dr. Mustafa is an assistant professor in physiotherapy at Sheikh College of Medical Science and Technology, Bangladesh. In addition, he teaches research and supervises undergraduates at the University of Dhaka and provides his services to many local and international organizations. He had done research on the efficacy of PRP therapy along with physiotherapy for the management of knee osteoarthritis and was awarded as an international inspection specialist for joint injection courses and PRP therapy course by Monroe Medical UK. I would kindly invite Dr. Mustafa Kamal to deliver his lecture from Bangladesh.
Hello, everybody. Me is Mustafa Kamal from Bangladesh. Thanks to the organizer and to the Sri Lanka Society of Physiotherapy. So this occasion is on the World Physiotherapy Day celebrations. So I'm very glad to have this place to share something about physiotherapy along with PRP also. So thanks to the organizer team, and a special thanks to the president and secretary and Dr. Kumar also. So now I am sharing my screen here. So can somebody tell me, is my voice is audible and my screen is visible to you?
Yes, sir, we can hear you, but we are only seeing your face, your screen, but not your laptop screen. But it's our logo is there. Is it your screen, sir?
Yes,
Okay,
yes,
so,
yes.
so we can see your screen, sir. Yeah.
Physiotherapy management of post-platelet-rich plasma, PRP for knee osteoarthritis. So currently I am working as the assistant professor at the Site College of Medical Science and Technologies. And also I am working globally to provide some international accredited courses. I'm a licensed trainer from the UK. The Monroe Medical is my associated organizations. Also, I'm working as a chief instructor of Academy of Physiotherapy. So what is osteoarthritis? As we all the professionals here and some students may be joining. So we know about the osteoarthritis. The motto of this year, the World Fit Days, was the osteoarthritis. So knee osteoarthritis is a type of chronic degenerative arthritis, and its chronic inflammation is characterized by degenerations or loss of articular cartilage, articular margin, and subchondral bony regenerations also. And if we look for the epidemiology of osteoarthritis, around the world, the 520 million people are suffering with the osteoarthritis. And the osteoarthritis is a chronic disabling conditions that affecting 10 to 15% of adults over 60 years of age. That means this osteoarthritis is more vulnerable for the older people. And 60% of osteoarthritis affecting commonly to the knee joint. And if you see the prevalence of symptomatic knee osteoarthritis is approximately 10% in men and 13% in women. That means the women are more vulnerable for the osteoarthritis rather than the male. So among the 291 conditions, osteoarthritis is 11 conditions which leads disability. So it's a global burden. So I'm talking about the global burden. So till 2017, the prevalence of disability due to osteoarthritis is 9.6 million. So from 1990 to 2019, worldwide prevalence rate of osteoarthritis has increased tremendously, and it's now is 48%. So it's a very, very concerning issues for the upcoming world populations also. So expenditure for the care of persons with osteoarthritis are approximately 15.5 to 28.6 billion per year. So it's really a global burden for our health economies. So etiology and pathogenesis of osteoarthritis. So currently, age, diet, trauma, obesity, and inheritance are the main risk factors. So if someone is growing, someone is getting aged, the older people are more commonly affected. So they may develop the osteoarthritis. Diet. So as with somebody else, if live with the sedentary lifestyles, so if they are fond of the junk food like this, so they will gain weight and they may develop the osteoarthritis. Trauma is one of the cause, and the obesity, according to the WHO, World Health Organization, if someone BMI is within normal range, they will be feel good. But if the BMI exists, if someone is obese, overweight, they will have the more chance to develop the osteoarthritis. So the articular cartilage layers is worn out, the biomechanical changes in contact with the subchondral bone, and the loss and reduction of articular fluid with the acceleration of the aging process. That means as we are going older, so day by day, our articular surface is getting erodes and our synovial fluid is getting lost. So in addition, with weight gain, ligament degenerations, relaxation, and muscle weakness, degenerative changes in articular cartilage and subchondral bone is happening. So sorry for the interruptions. Of ONE, especially in Bangladesh. So I used our city randomized control trial and And I found the prevalence, I mean, the p-value is 0.015. So if we use the PRP therapy, and if we use the PRP therapy along with physiotherapy, is physiotherapy and PRP therapy is more effective for the management of osteoarthritis rather than only the PRP therapy. So now, what are the aims of physiotherapy? For the care of osteoarthritis, there are the sequential aims. As we are the physiotherapist, we have to set these aims, and we have to try to fulfill the aims also. To educate patients to avoid high impact axial loading. That means we have to educate patients and we have to ensure that the patient is not bearing the axial loading. And to decrease pain, to increase range of motion, and my previous speaker also mentioned range of motion is important. And to increase muscular strength, and to improve physical fitness, to improve gait training also. So what sorts of treatment for osteoarthritis of knee? So if we look for the evidence, we'll found this 4 strategy for the treatment of osteoarthritis is lifestyle measures. So lifestyle measures, what will be in the lifestyle measures, the maintaining a healthy weight and exercising regularly. So as we know from previously that excessive weight may lead to the osteoarthritis, the regular exercise to maintain our healthy weight also. Supportive therapies to make help everyday activities easier. So we have to provide the supportive therapies as people can do the activity of daily living in easier ways. Some medications to relieve or alleviate the pain, and if needed, surgery. My previous speakers, Dr. Chill, that PRP is working on the grade to moderate osteoarthritis, but in case of severe osteoarthritis, PRP will not work. So if we found the severe case of osteoarthritis, so surgery is recommended if the conservative management is failed. So we'll focus on these 4, the lifestyle measures, supportive therapies, medication, and surgery. So look to this images. So it's a guideline developed by the WARSI. WARSI stands for Osteoarthritis Research Society International. So this ORC has developed a guideline for multidisciplinary team. So this ORC is developed by 16 experts. Within that 60 experts, there are 4 different medical professionals who developed this ORC guideline for the management of hip and knee osteoarthritis. So they did some research also in 6 countries, including the USA, UK, Netherlands, Sweden, Canada also. So what were in this guideline? There are many guidelines for the management of osteoarthritis, but among these 12 are the evidence-based. So this 12 evidence-based treatment we can perform as a physiotherapist. So physiotherapy for osteoarthritis of knee. Look the treatment regimen. What treatment regimen we can use as a physiotherapist? The strength training, strengthening, our aim is to improve the muscle strength and to reduce pain. And fitness walking, aerobic exercise, aquatic or hydrotherapy, and some sorts of electrotherapy, including the magnetotherapy also. So what will be the doses about our physiotherapy sessions? So can we give this physiotherapy every day? No, we have to follow a formatted doses based on the evidence. So treatment session will be 6 to 24 weeks, average 8 weeks. So we can provide the physiotherapy average 8 weeks and 3 sessions in a week. That means in a week, we have to provide 3 sessions of treatment, and average treatment duration will be minimum 30 minutes. So why physiotherapy required after having PRP therapy? So very important. So PRP therapy can regenerate the degenerative articular cartilage or structure damage within joints. That means if due, it will develop the damaged cartilage again. I mean, regeneration will be started there. Okay, within the inside, I mean, inside the joints, if articular cartilage has damage, the PRP therapy can regenerate this. PRP can alleviate pain, but cannot improve mobility along with functional ability. So if somebody have a PRP, patient may feel the of pain, but the mobility would not be increased up to the expectations. So if there is a no mobility up to the expectations, I mean, if there is a no functional mobility, then people or patients cannot do the ADLS normally. So after having the PRP, if we give the physiotherapy, I mean, those will improve the mobility, those will improve the functional ability, these kinds of physiotherapy. So patient will get the full recovery. Cannot improve, I mean, this PRP cannot improve muscle strength. Yes, it's true, PRP cannot improve the muscle strength, which is the major concern of failure of PRP treatment for the osteoarthritis. What does this failure? If somebody take the PRP therapy and after a few months, patient will complain again, yes, I am feeling pain and I cannot walk properly and I am feeling the weakness to my knees. So after having the PRP, if we provide the strength training as a physiotherapist, so patient will develop the muscular power. I mean, they will develop the muscle strength at the surrounding muscle at the knee, and patient will be able to walk and can return to the functions also. And PRP cannot normalize the gait patterns. So if someone has the abnormal gait pattern due to having the osteoarthritis, if that patient take PRP therapy, patient would not be able to walk normally because already patients develop the abnormal gait patterns. So here is the major rule as a physiotherapist, you can play a major role to normalize the gait pattern. So we have to start the gait training. So I will demonstrate some practical in front of you to make you better understandable how we'll provide the physiotherapy treatments for the osteoarthritis of knee after having the PRP. So now I'll arrange my setup here. I'm taking a minute. So I'm requesting my, I have two models in front of me to demonstrate the treatment regimen here. So I'm requesting my model to demonstrate the strengthening exercise. I mean, not only strengthening exercise, those treatment is required, or we can patients after having the PRP therapy for the betterment of the patients, that treatment I will demonstrate in I am showing you I'm moving my camera towards my model. So it's a bit difficult to observe, but I am making it. I'm trying my best to demonstrate in front of you. So can anyone tell me, is it visible to you? Can
Yes, sir.
anyone tell me, is visible to you my model?
Yes. Yes, sir.
Yes,
Definitely.
yes.
So I'm requesting to my model. I'm requesting to my model to demonstrate the strengthening exercise for the osteoarthritis, strengthening exercise for the quadriceps muscles. So patient should be in lying positions, I mean supine lying positions, and the clinician will put a pillow just beneath, I mean underneath to the knee, and I am my model. I will instruct to my patients to pressure to the pillow by using the knee and have to count for at least 10 to 15 seconds. So after counting, then patient will release the pressures, and we have to perform this for 10 repetitions. I'm not showing 10 repetition here, one is enough. So next, next technique is joint play technique. So now I will demonstrate the joint play techniques. I'm requesting to my model, please demonstrate a joint play technique to my patient's right knee joints. So my patient will be in a lying position, supine lying positions, and the clinician should be sit just in front of the affected knee, and clinician will hold the upper portion, I mean upper part of the tibia, and have to put the both thumb over the tibial tuberosities. Joint play technique. Okay, by keeping the traction, they will do the vibratory motion. Do the vibratory motion.
Sir,
It's
sorry to
difficult
disturb you,
observe,
but your
we are
demo is
trying.
not properly.
So have to do the vibratory
giving.
motions, 6 repetitions. So it will improve the joint mobility and will reduce the pain also. So now I'm requesting to my model to demonstrate the mobilization with movement techniques. It's a Mulligan approach. It will increase the range of motion of the knee and will decrease the pain. So patients should be in standing positions if possible, and therapist, I mean clinician, will stand beside the affected knee and they will use a Mulligan belt. The belt should place just below the knee joint, and clinician will hold the lower thigh to the opposite directions. And now we have to instruct our patients to do the squatting movement. It's called semi-squat. Along with the squatting movement, the clinician should go down. So this should be continue 6 repeats. Okay. So now come to the second, the knee joint mobilizations. So it will improve the joint range of motions and also will reduce the pain. So patient should be in supine lying position. And I'm requesting to my model to demonstrate. So clinician will use a towel and patient knee should be 60° to 90° flexion on the couch. And the clinician will use a towel to do the mobilization to the knee. The both sided he's doing a one-sided mobilization, and I'm requesting you to do the another side of mobilization. Okay. So the pendulum exercise. So if patient have a lot of pain, I would not able to walk or stand that time to relieve the pain and to improve the mobility, we can advise the pendulum exercise. So for pendulum exercise, we'll recommend, advise our patients to sit on a high couch as the patient's foot is hanging, not touching to the floor. Look. So my patients, I am requesting you to do the pendulum exercise to your one knee. Look, it's moving. It should be move freely. And if patient is able to move freely, so we can use some added weight, or we can hold the foot towards the gravity, So I'm requesting to my model to put the foot towards gravity and make the pendulum. Yes, like this. It will keep some traction forces also. So next one is the gait reeducation. So if patient has a problem with the gait, if somebody has the abnormal gait pattern, then we can start the gait reeducation. So if gait reeducation is needed for people who are working with the abnormal gait on low. So these were my practical sessions. I'm a demonstration. I'm sorry I could not show you very properly. It's difficult to show through the online because I tried to use the live demonstrations. So I have completed my sessions. It's my sharing sessions. If you have any questions, you can ask me.
Thank you very much, sir. It's very informative. If anybody have doubts, you can put on the chat or raise hand so we can ask from sir.
Is there any question?
Still not, sir. If you have any questions, please put on the chat so then we can discuss further. So there's a question. Sir, PRP can be used in RCT surgery had done, but after 6 months, patient had mild pain, mainly supraspinatus origin muscle. It can be used.
Okay, thank you for
Sir, your mic was muted, sir. Still it's muted, sir. Sir, your mic was still muted.
Hi. Hi, Dr. Mustafa. How are you? Actually, it's a nice presentation.
Sir, your mic was muted. We can't hear you.
A minute. Now you can able to hear.
Okay.
Sorry, is it audible to you?
Now it was audible, sir.
Okay, can you repeat the question, please?
The question was, sir, just give me a minute.
Please.
Sir, PRP can be used in rotator cuff surgery, I think so, had done, but after 6 months, patient had mild pain, mainly supraspinatus origin muscle. It can be used.
Yes, yes. We can use the PRP therapy to the rotator cuff injury also. But after having the PRP to the condition, we must have to apply the physiotherapy. So what sorts of physiotherapy we need to apply? We have to focus on the strength training. What is happening after having PRP? If somebody take the PRP, patients will feel better. I mean, patient's pain will go. So, but it will not improve the strength. So if patient does not have pain, patient will do all kinds of activity that times.
Okay. Sir.
So if patients is doing all kinds of activity, that time what will happen, the muscle strength will go down. I mean, wasting will happen there. So if you will find a lot of studies in PubMed, I mean, PubMed and Scopus also, they are showing if somebody take the intra-articular injection, I mean, the steroid, cortisone, PRP, or hyaluronic acid, they might develop the wasting of the muscles. So we have to focus on the strength training. We can start with the isometric and later we'll progress to the eccentric strengthening. So in worldwide, the eccentric strengthening is very popular right now to develop the muscle strengths. So in that conditions, we can use the PRP, and after having PRP, we must have to apply the physiotherapy treatments.
Sir.
Is there any question?
Yes, sir. There are 3 questions. And the second question is, at what stage of OA we can use the mobilization? At what stage of osteoarthritis we can use the mobilization?
Okay, well, in osteoarthritis, in case of the grade 1, grade 2, I mean mild to moderate stage, we can use the mobilization. But in case of stage 3, I mean the severe stage of osteoarthritis, we can also use the mobilizations. Depends how much force you are giving. That means mobilization has 4 stages. If you talk about the Maitland mobilizations, there are 4 stages. So stage 1 and stage 2, we are using to relieve the pain. And the stage 3 and 4, we can use to improve the range. If we think about the severity of the osteoarthritis, then to the severe cases, we should not use the stage 3 and stage 4. We can use the stage 1 and stage 2 mobilizations.
Okay, so the next question is, sir, commonly I saw osteoarthritis patient with Baker's cyst. Can you tell us any physiotherapy management for that?
Yes, definitely. So Baker cyst is a common complication of osteoarthritis. So if patient have the osteoarthritis might develop the Baker cyst. So it's very difficult to manage by the orthopedician also. So orthopedician is doing what? They are trying to aspirate the fluid from the Baker cyst. They are trying to aspirate the fluid. But if they're doing the aspirations after a few days or weeks, the cyst will be filled by again you will find the fluid. So physiotherapist is doing what for the Baker cyst management? So we have to use the soft tissue techniques, some pressure bandage, and some lymphedema management. So we can use the lymphedema management here. By these we can manage the Baker cyst also. And the joint play technique is very effective to management for the Baker cyst also. Try for the joint play technique and pressure garments bandage and lymphedema. Next question.
Next question is, sir, for patient with abnormal gait due to knee osteoarthritis, to what extent can standing and weight bearing be helpful to them?
Can you repeat the question, please?
So he was asking the patient with knee osteoarthritis, how the weight bearing exercise in standing will help. Shall I repeat it, sir,
my
again?
connection is maybe problem. So I'm not audible to you. I'm not hearing.
I can hear you, sir. Can you hear it now, sir?
Can you hear me?
We can hear you, sir.
Yes, please.
Okay. For patient with abnormal gait due to knee osteoarthritis, to what extent can standing and weight bearing be helpful to them?
Yes, for patients with abnormal gait due to knee osteoarthritis, to what extent can standing and weight bearing be helpful to them? Yes. So if patient has the patient has the osteoarthritis in a stage of 1 and 2, I mean grade 1, grade 2, if patient do the weight bearing on even surface, then it will stimulate the articular cartilage and the synovial fluid also. The exchange will be improved, the nutrition within the joint will be improved. But if patient is trying to work on uneven surface, like they are walking, I mean staring up, they are walking in the heel track area, is difficult to work. So with the abnormal gait, we have to try to correct the gait pattern first. So we have to do the biomechanical gait analysis. So what sorts of gait deviation is there? We have to try to manage this gait deviation first. After that, we can start the others remedy also. But in case of severe osteoarthritis, we should avoid the weight bearing with the abnormal gait.
Okay, the next question is, sir, what is the difference between physiotherapy treatment after giving PRP and surgery for osteoarthritis? Is it same procedure or not?
Okay, what is the difference between physiotherapy treatment after giving PRP and the surgery for osteoarthritis? Yes, is different, because if somebody have a PRP therapy, so they can work immediately. But if somebody have the surgery, they cannot work immediately. So we have to give the post-operative physiotherapy management to the patients who have the knee surgery. But if somebody have the PRP, then we can start the physiotherapy after 72.
Okay,
Next
sir.
question, please.
That's all, sir. Thank you very much, sir. That's a wonderful session.
Thank you, Dr. Mustafa, for that valuable addition to the World Physiotherapy Day celebrations. Our third speaker is Dr. Rasanga Lakmal Gunawardana, consultant orthopedic surgeon and senior lecturer in the Department of Surgery at the Faculty of Medicine, University of Ghana, Sri Lanka. He will talk about knee arthroplasty for knee osteoarthritis. Dr. Gunawardana had received his medical degree from the Faculty of Medicine, University of Colombo. He had received his Doctor of Medicine in Orthopedic Surgery from the Postgraduate Institute of Medicine, Colombo, Sri Lanka, and is currently a member of the Royal College of Surgeons, England. I warmly welcome Dr. Rasanga Lakmal Gunawardana, consultant orthopedic surgeon and senior lecturer.
Good evening, everyone. Can you all hear me?
Yes, sir.
All
Of
right.
course.
Yes,
All
sir.
right. So, first of all, I would like to congratulate Sri Lanka Society of Physiotherapy for organizing this international webinar, and I hope it would be a great success. And thank you very much for the organizing committee for inviting me, especially Mr. Kumar Senanayaka, personally invite me for this event. And can you all see my screen?
Sir, we
Sir.
can see, sir. Yes,
Yes,
sir.
sir. Of course.
Yeah, you can see. All right. So today we are going to discuss about knee arthroplasty for knee osteoarthritis with important concept which will be beneficial for all our physiotherapy colleagues. So first of all, we'll see what is the indication for the objectives of this lecture. So first one is indication for arthroplasty, and I'll touch about non-arthroplasty surgical option to make this lecture complete, and we talk about types of knee arthroplasty and a bit about the history or the evolution of knee arthroplasty, the concepts in prosthesis design, surgical approaches, some recent advances in knee arthroplasty, and finally the complications of knee arthroplasty. So hope most of the topics will be beneficial for all of you, the participants. So what are the indications for arthroplasty? First of all, our main aim is to relieve pain caused by severe knee arthritis, especially following osteoarthritis or inflammatory arthritis, and cartilage space loss confirmed on radiograph, severe pain from even gout, pseudogout, or chondrocalcinosis, and severe progressive deformity. And finally, the exhaustion of non-surgical treatment, which we all know we give for osteoarthritis, the non-steroidal anti-inflammatory drugs, injections, activity modifications, and physical therapy, and etc. So once these are exhausted, the only option available is for knee arthroplasty. So what are the contraindications for knee arthroplasty? So one is active ongoing infection. Second one is incompetent extensor mechanism. and compromised vascularity in the lower limb, recoatum deformity secondary to muscular weakness, any local neurological disruption affecting the muscles around the knee, and presence of a painless, well-functioning arthrodesis, and any medical conditions precluding participation in a rehabilitation program or the patient who is not fit for anesthesia. So there are some non-arthroplasty surgical treatments which are offered for knee osteoarthritis. I'm not going to go into details on these things, but for the completeness, I will mention it here. There are arthroscopic management of arthritic knees, osteotomies like high tibial osteotomy, and cartilage reparative and restorative procedures, and all the non-technique knee arthrodesis. All right. So when you talk about arthroplasty, there are few variations in arthroplasty. So one is total knee arthroplasty. We all know we replace all articular surface, the femoral condylar and the tibia and the patella articular surface. So that is the total knee arthroplasty or the total condylar arthroplasty. And then there will be unicompartmental knee arthroplasty, where we replace only the affected compartment, mainly medial, but sometimes laterally, and isolated patellofemoral arthroplasty. So what is the success of total knee or total condylar arthroplasty in literature? So the survival rate for total condylar or total knee prosthesis range from about 91 to 96% for about 14 to 15 year follow-up. And the rates will differ with different types of prosthesis. For posterior cruciate ligament remaining type of knee arthroplasty, it's about 96 to 97 at 10 to 12 year follow-up. And for the PCL substituting type, 97 at 10 years and 94 at 13 years. And survival rate for cementless range for about 95 to 97 at 10 to 12 years. So we all know these have proven result for good results for total knee arthroplasty. Then unicompartmental arthroplasty. We do this operation for certain identified specific indications. The criteria are mainly for non-inflammatory arthritis, purely osteoarthritis, less than 10 degrees of varus or less than 5 degrees of varus deformities, and intact anterior cruciate ligament, and the patient should have at least 90 degrees of flexion and without any evidence of mediolateral subluxation. There shouldn't be any FFD or flexion deformity, should be less than 15 degrees, and all the deformities should be correctable. And there should be no collapse in the opposite compartment in the X-ray. And the patellofemoral OA also should be less than grade 3. And the main thing is the patient has to be less than 90 kilograms in weight. Okay, so this procedure offers advantage for two specific groups of patients. One population is the middle age or with younger patients, which we did osteotomy initially, but now we have the option as a unicompartmental arthroplasty. The advantage in this procedure in this group is they have a higher initial success rate and few complications with more acceptable cosmetic appearance and long-lasting results. And we can easily convert into a total knee arthroplasty if the other compartments degenerates. And octogenarians, or the people who are old enough, who are not expected to outlive the implant life. So these people are very old people. This will give a faster recovery with less blood loss and less medical morbidity following surgery, and the expense also less. And if you take the results of unicompartmental arthroplasty, the first decade results are good. The 10-year survival rates range from 87.4 to 96. And the standard failure rates in the first decade is less than 1% per year. So second decade results, there's a rapid decline in survivorship is noted. The 15-year survival rates range from goes down to 79 to 90%. Okay, so the patellofemoral arthroplasty or the isolated patellofemoral replacement indicated for isolated patellofemoral osteoarthritis, post-traumatic arthrosis, severe chondrosis outreach grade 4, and failed non-surgical treatments. And patients who are symptomatic during prolonged sitting, stairs or hill ambulation or squatting will get benefited. The results are like this. It's about 85% good to excellent results are there. The failures are usually associated with uncorrected alignments and progression of the tibiofemoral arthritis. And the higher failure rates are reported in some poor functional outcomes, which are correlated to the implant designs. And the cemented versions are with good outcome. So evolution of arthroplasty. How has this evolved into the current total knee arthroplasty? So in 19th century, they were tried interposition of soft tissues for reconstruction of the damaged articular surface. They have used a lot of ingredient products and tried. And by about 1950s, the Waldis designed the first hinge knee replacement. And by 1958, they have introduced acrylic tibial plateau processes mainly to correct deformities in the knee joint. So these are some of the pictures which I could get it from web. And by around 1960s, the first cemented surface arthroplasty of knee joint was introduced. And there were improvement of the Valdez hinge by 1970. And by about 1973, the total condylar prosthesis is introduced, which is first to resurface all three compartments. At it was a PCL sacrificing arthroplasty. So this is how it has evolved up to the current arthroplasty practices. Okay, there are several concepts and processes which will be important for a physiotherapist also, because we all want to get a better near normal knee kinematics after surgery. So the concepts are evolving quickly, but there are things which are important to mention here. So one thing is the femoral rollback phenomenon, the constraint of the implant, the modularity, and the fixation. And mainly the designs. What are the designs available now in the market? So femoral rollback, by definition, is a posterior translation of femur with progressive flexion. So the importance of this is it improves the quadriceps function, and mainly the range of knee flexion will be improved by preventing the posterior impingement of the distal femur during deflection. So this is very important in this Asian culture, where the patients tend to go for deep flexion for their cultural practices. So this is very important to get the deep flexion. So biomechanics will be normally in a native knee. It was done controlled by the ACL and PCL, and designs, both PCL retaining and PCL substituting designs, allow for some sort of a femoral rollback to allow full flexion. So constraint by definition is the ability to prosthesis to provide the varus valgus or flexion extension stability, especially in the face of ligament laxity or bone loss. We all know we get to operate on patients who have different degrees of ligament laxity or damage or bone loss because of the delay in presentation sometimes. So important is, if there's a ligament laxity or severe bone loss, the standard cruciate retaining or posterior stabilized implant might not provide enough stability, especially varus valgus. So the design has gone from cruciate retaining, posterior stabilized design to varus valgus constrained non-hinge design, and for the more constrained rotating hinge type arthroplasty to get this varus valgus and flexion extension stability. So modularity, again a definition where the ability to augment a normal processes when there's a soft tissue or bone loss, and the options include metal base plate with modular polythene inserts and modular femoral and tibial stems with extension. An advantage is we can customize the implant intraoperatively depending on the bone loss or the deformity. But the disadvantage is there's an increased risk of osteolosis in modular compartments and backside polythene wear. So the fixation, most of the time it's cemented. There's a proven survivorship and function due to high viscosity cement, which has a long working time, and sometimes they are antibiotic impregnated. And cementless, the trabecular surface allow for long-term biological fixation with trabecular metal. So the designs are, we divide the total knee arthroplasty designs into unconstrained, posterior cruciate retaining, or posterior cruciate substituting, and constrained types are non-hinge and hinge knee arthroplasty. And there's fixed versus mobile bearing also. I'll just touch on this concept. The posterior cruciate retaining is where the design, it's a minimally constrained processes that the function is dependent on an intact posterior cruciate ligament, provides stability in flexion. We don't remove the posterior cruciate ligament in this type of processes. So this is how it appears in the X-ray. And it won't show the box in the central portion of the femoral component as in a posterior stabilized. You will see the next X-ray in the next slide. So the advantage, the indications are the arthritis with minimal bone loss and minimal soft tissue laxity and an intact PCL for the posterior cruciate retaining implants, and the varus deformity less than 10 degrees and a valgus deformity less than 15 degrees. Advantages, it's avoid the tibial post-cam impingement or dislocation which can happen in a posterior stabilized knee, which I will explain later, and most closely resemble normal knee kinematics. It's also a controversial topic, but the less distal femur cuts need in PS than the posterior stabilized knees, and the improved proprioception because of the preservation of the native PCL. There are disadvantages also. A tight PCL will cause accelerated wear, and loose or ruptured PCL lead to flexion instability after the surgery. Then the next option is for the posterior cruciate substituting type, where we will cut the posterior cruciate ligament during the surgery. So it's more constrained, but requires a sacrifice of posterior cruciate ligament, and it will increase the flexion gap when you resect the PCL, and it has to be meshed to avoid any mismatch in the flexion and extension during the knee movement. And femoral component has a cam a box that engage the tibial polyethylene post that will give the function of PCL, and they are more congruent and deeply dished and more stable. So when you take the lateral radiograph, it will show, as the arrow shows, outline of the cam or the box in the femoral component where the polyethylene stem going. So the indicated, especially with people with previous patelectomy and it has reduced the potential anterior posterior stability, especially in the people of with weak extensor mechanism. And inflammatory arthritis, when there's a late PCL rupture, this type of implant is indicated, and especially people who don't have PCL or absent PCL. Advantages: it's easy to do balance the knee with absent PCL, and more range of movement, and early surgical exposure because we remove all the soft tissues. And at disadvantages, this cam jump mechanism, where with loose flexion, the cam can rotate over the post and dislocate, and tibial post can go into wear. And there's another phenomenon called patella trunk syndrome, which I will discuss later with the complications. Then more constrained one is a non-hinge design, and it without the axial connection, without a hinge, but it is more constrained. And the large tibial post and deep femoral box will give more stability. Indicated especially for ACL, MCL deficiency, and if there's a flexion gap laxity, and sometimes in moderate bone loss in the setting of neuropathic arthropathy. So the radiograph will show this special implant with more longer stems in the femoral and tibial canal, and more deep dish which cannot be seen in the X-ray. But we can see in the implant picture the deep dish and the tibial post will give the stability, which is more than in a posterior stabilized knee. So then the advantages: it allows stability in the soft tissue or bone deficiency. Disadvantages: we have to resect more femur bone and to accommodate the large box, and there's a risk of aseptic loosening due to the increased constraint. Then the constraint hinge, the ultimate constrained implant, is the most constrained, and there's a link in between the femoral tibial component like a hinge. So it can rotate around a yoke in the tibial platform, and it will give us good constraint. And indicated in global ligamentous deficiencies, there are people with all ligament deficiency where we cannot do a standard total knee replacement. Then this would be the ideal implant. And especially with hyperextensive instability seen in polio or tumor resections, when you remove a lot of soft tissues and bone, we cannot get the stability from the ligament. So we have to rely on a constrained hinge design, and especially in a massive bone loss setting. And you can see the radiograph where the femur, there's a massive bone resection, and it is replaced by the hinge knee replacement with modularity allow the implant to get the correct length of the limb. So this is a constrained hinge type of a design. When you see the X-ray, you can see. So allow stability, and the disadvantage again is the aseptic loosening as a result of increased constraint. And sometimes you need to remove large amount of bone. So mobile bearing again is a concept where you will allow young inactive patients to rotate the tibial, the polyethylene insert over the tibial base plate. So advantage is reduced polyethylene wear due to increased contactless area. Disadvantage is it can spin out because there's a no tight fix. And you can see here the polyethylene insert can rotate on the tibial base plate. It will give more movement theoretically. So up to now we have discussed about the evolution and indications and the concept in general or knee arthroplasty. Now I will touch on the surgical approach, which will be important, especially in rehabilitation with the physiotherapy point of view, depending on how we cut the muscles, the rehabilitation protocols may change. So I will touch on the some of the surgical approaches which are used for total knee replacement, and understanding that will help for a better rehabilitation with physical therapy. So the surgical approach is mainly Can you all hear me?
Yes, sir. We can hear you, sir.
Yeah, we can see the slides also. All right, thank you.
Yeah, sure, sir.
And yeah, okay. So the surgical approach is dictated by the surgeon preference, the prior incisions, and degree of deformity and patella bargia, and if the patient is obese. So when you talk about the approaches, there are simple or the primary knee arthroplasty approaches, which are the commonest medial parapatellar approach, the mid-vestus approach, subvestus approach, and lateral parapatellar approaches. And there are now minimally invasive surgical approaches. But when you go to complex procedures, they are done in some primary and mainly in revision total knee arthroplasty. So these are quadriceps snip, VY turn down, and tibial tubercle osteotomy, where we need a good approach in complex cases. So I'll touch on these standard approaches. So the standard medial parapatellar approach is the most commonly used approach. The skin incision will be a straight midline, and then we'll go for the medial parapatellar approach. So you can see the black line depicts the line of incision over the approach. Okay, so the advantage over here is familiar with most orthopedic surgeons, and it will give external exposure because we can get the patella everting very easily, and even in challenging cases. The disadvantage is there's a possible failure of medial capsular repair, and development of lateral patellar subluxation due to that. The lateral reticulum access is less direct with this medial approach, and it can harm the patellar circulation if there will be both lateral and medial release. So the mid-vestus approach is another approach where, similar to the skin incision, is similar to the medial parapatellar, but it spares the vestus medialis obliquus insertion and may lead to quicker recovery because the less cut into the extensor mechanism. I hope you can see the image, and the black line depicts the approach. So advantage is the insertion on vestus medialis, insertion on quadriceps is minimally disrupted and allowed accelerated rehabilitation due to the extensor mechanism is not disrupted, and patellar tracking may be improved because of compared with the medial parapatellar approach. Disadvantage are less extensile, and especially in obese patient with this limited approach, we might not be able to get a good exposure, and especially with flexion contractures, the exposure is difficult. So there's a small risk of partial denervation of VMO muscles, and contraindicated, especially if the range of movement is less than 80 degrees, and especially in obese patients. And hypertrophic arthritis, where there are a lot of osteophytes we have to approach and remove, and previous high tibial osteotomy. Then there's a subvestus approach. So the muscle belly of vestus medialis is lifted from intramuscular septum without damaging the muscles. So it is a very less extensile approach. So the patellar vasculature is preserved, and the extensor mechanism remain intact throughout, and minimal need for lateral reticular disease. And disadvantage are less extensile, and relative contraindications are especially in the revision TKR, and when if the patient has large quadriceps, we won't be able to have a good exposure with this method, and again with previous operations like high tibial osteotomy. And obese patients, it's very difficult to get a good exposure. And previous parapatellar arthrotomy is also a contraindication. So the lateral parapatellar approach is we use it limitedly only for difficult because it has difficulty in inverting the patella, and it is on the lateral side. The advantage is that is done for fixed valgus deformity, especially the people who are coming in rheumatoid arthritis who have a valgus type of deformity where we cannot correct it with the medial approach. But the good advantage is preserve the blood supply for patella, and the lateral patellar subluxation is prevented and give a good access for the lateral side to clear the tissues. Disadvantages are technically demanding because it is difficult to evert the patella, and the medial eversion of the patella is difficult, and sometimes might end up with tubercle osteotomy. And there are minimal invasive surgical approach in view of getting less scar, but they often need special instrument for exposure and implant insertion, and technically demanding because the exposure is very less. And outcomes, short-term data supports more rapid recovery because the muscle cut and the skin cut and the soft tissue handling is minimal, but long-term data need to compare outcomes and with the traditional exposures. The problem with this, when you go with minimal invasive, there's a high chance of the implants go into malposition due to minimal exposure. All right, so those are the standard approaches, and then we have this extensile exposures, which are important because there we are going to disrupt the quadriceps mechanism. The rehabilitation will be not easy as in a simple exposure. So one is the quadriceps snip. The technique is we made a snip at the apex of quadriceps tendon obliquely across the tendon at 45 degrees angle to the vastus lateralis. So the advantage of this procedure is there's no much change in the post-operative protocol. Minimal if there's any long-term consequence. Disadvantage is it is not very extensile as the tibial tubercle osteotomy. So the next one is the VY turn down, where we had a straight medial parapatellar arthrotomy and a diverging incision along the down the vastus lateralis towards the lateral retinaculum. So there we have the advantage of allow excellent exposure to the knee joint, and we can because this VY procedure can use for lengthening of the quadriceps tendon if there's any contracture, and it will preserve the patellar tendon and the tibial tubercle when comparing with the tubercle osteotomy. But there are disadvantages. The extensor leg will be there, and it will affect the quadriceps strength, and the knee need to be immobilized post-operatively, regain the continuity of the quadriceps tendon. So we might not be able to go for the normal physiotherapy protocols following these turn down procedures. The next one is tibial tubercle osteotomy, the ultimate exposure, where we take about 6 to 10 centimeter bone fragment from the tuberosity, and then later fix with screws or wires. The advantage is the exposure is excellent. We can see, visualize everything, and it will not have any problem in the quadriceps tendon, and it will avoid the quadriceps weakness. But the disadvantages are we have to immobilize the patient or limit weight bearing till the osteotomy site heals, and there can be avulsion fracture later, and there can be non-union of the osteotomy and wound healing problems also. Okay, now this concept of bilateral knee arthroplasty is worldwide practiced. When we have bilateral osteoarthritis, we will go for this bilateral total knee arthroplasty, So most of them do simultaneously. So sometimes two surgeon or even one surgeon performing, two surgeons performing bilateral TKA at the same time with the given same anesthesia, and sequential is the one single surgeon performing one TK and then go to the other side under one anesthetic. So that is sequential. And stage one, so surgeon doing TK under separate anesthetic with a range of 3 days to 1 year in between each side. So people with bilateral total knee arthroplasty can undergo bilateral total knee arthroplasty in these methods. All right, so I will not go into the bone cuts and every thing in the surgery. Now, another important management is the pain management, which is help the patient to recover soon and help the patient to go into physiotherapy protocol soon. When there's pain, it's very difficult to follow up a proper physiotherapy management. So it's a very important part of knee arthroplasty is the pain management, because it's a very painful procedure with the bone cuts and things. So patient will have significant pain, but if you manage pain properly, the post-operative protocol will be adhered correctly and patient will be mobilized soon. So we start with pre-operatively. We can give non-steroidal anti-inflammatory drugs and opioids immediate procedure before the procedure, preemptive analgesia, and intraoperative, the regional anesthesia, spinal or epidural are preferred, and peripheral nerve blocks give more coverage or to decrease the post-operative pain. And multimodal drug injections, periarticular, some surgeons practice. There are evidence for and against it, and it will decrease the post-operative pain. Then mainly post-operative, it's a multimodal oral drug therapy plus IV or subcutaneous treatments, starting with NSAIDs, which inhibit inflammatory media, and opioid, which act against mu receptors, and gabapentin, pregabalin also used for reduced hyperexcitability of neurons, and serotonin and noradrenergic reuptake inhibitors. So physical therapy, I will not go into detail. My colleagues will discuss it in the coming lectures. But usually it has to be we can start on the day of the surgery or so that it will reduce the length of hospital stay, reduce pain and improve function, and the range of movement requirement are for the gait swing pace, at least we need 65 degrees of flexion. And for activities of daily living, we have to get about 90 degrees of flexion. For the stairs, about 95 degrees of flexion in the knee. And for rise from chair, we need around 105 degrees of flexion. Those are the requirements. And discharge home criteria following total knee arthroplasty, mainly medically stable without any complications, acute complications, and around 80 to 90 active range of movements, and should be able to ambulate about 70 to 100 feet, and will be able to ascend or descend at least a flight of stairs. So I will touch on some new concepts in knee arthroplasty, which are patient-specific instrumentations, individual knee arthroplasty implants, sensors, accelerometer, robotic. I will go quickly just to get an idea what are the new things happening in the world of knee arthroplasty. So one concept is patient-specific instrumentations. We do 3D modeling, 3D imaging, and make implants according to the, especially the bone resection guides according to the patients, and they will be printed, 3D printed, and we send it to the operation theater, and it will use to get the personalized cutting guides to get cuts for these individual patients. So they will be like that. It will 3D printed according to the CT or MRI scans of the individual patients, and you will get the specific cuts for that individual. So it has advantages of getting precise cuts. And there's this concept of individual knee arthroplasty implant. As you all know, we usually take over the counter, over the shelf implants according to the size which is available from each company. But individual arthroplasty, we make an individual implant with 3D modeling to the patients, and that is inserted following a personalized cutting blocks. So another new technology used in TK arthroplasty is sensors, where to get the optimum ligament balance, which if there's to limit the human error. So there will be sensors attached to get the correct soft tissue release and balance. And the monitor will show you the correct tension in the tissue. Then we can do the correct balancing with the improvement of the accuracy. And accelerometer also again sensor used to check the mobile one, check the alignment and the tissue tension in the bone. So it is use small sensors and capture it and see in a tab where we can align the femoral and tibial resection guide according to the data on the sensor, the monitor. All right, other thing is the robotic assisted knee arthroplasty, where you use what we do is have a 3D plan based on preoperative CT scans, and a robotic arm is helped to get the precise cut. So the human errors will be reduced, and it will get the precise cuts during the surgery, and it will improve the function of the joint, the replacement. All right, so I just went through some of the new concept in total knee arthroplasty, and there's another important concept. This is about the complication of total knee arthroplasty. As we all know, you are the people who are seeing the patient after surgery, and it's good to know what are the complications to be expected, and to refer the patients if you suspect if the patient is having leading to one of these complications. So it is always important for you all to know what are the complications following total knee arthroplasty. So there will be wound complication, prosthetic joint infections, vascular injury, peroneal nerve palsy, periprosthetic fractures, extensor mechanism ruptures, patellar maltracking, instability, aseptic loosening, patellar clunk syndrome, and joint stiffness, and heterotrophic ossification. So total knee arthroplasty is a very complex surgery. There are a lot of things involved, the processes, exposure of the bone, and a lot of tissue handling. So there can be a lot of complications associated with total knee arthroplasty, but it's always better to identify them and treat it, refer to the operated surgeon. Okay, so wound complications we see as a result of underlying systemic factor or direct trauma post-operatively. Diagnosis done with presence of incision breakdown or decision of the wound, and treatment depend on the size of the wound and the medical conditions. So the periprosthetic infection is very important to identify. It's a serious complication of knee arthroplasty, and it's a common cause for revision arthroplasty. In diagnosis is made by seeing the inflammatory markers and radiographic changes, and you need to give antibiotics or revision arthroplasty. And vascular injury and bleeding also can be there. So potentially devastating following TCAR due to the damage to the popliteal artery. So usually these acute complications which we identified soon after surgery. And there's a concept called the peroneal nerve palsy, which can happen due to damage of the peroneal nerve, especially with valgus knees with a flexion deformity. When you correct it, there can be stretching of the common peroneal nerve, and diagnosis is clinically made up with decreased sensation in the peroneal nerve distribution and weakness of the dorsiflexion. So most of the, I think when you are doing the physiotherapy, you might detect this weakness and always alert the clinician, because this has to be treated, especially just post-operatively. You have to put the knee in flexion to reduce the tension on the peroneal nerve. And sometimes in India, process orthosis to prevent foot drop. And we need to monitor the recovery of nerve. So that is an important complication. It's rare, but need to identify quickly and treat. And periprosthetic fracture can happen during any time. So it's a devastating complications, and you might see patient coming with pain and unable to move. So if you do the X-ray, you might have this complications. Distal femur, proximal tibia, or patella can be fractured. Diagnosis with X-rays, and treatment could be if it's undisplaced, non-operative, or displaced operative, depending on the location and the implant stability. So extensor mechanism rupture also can happen. This can happen during the rehabilitation process also. So it can rupture the patellar tendon or the quadriceps tendon. And the X-ray, in clinically, patient sudden onset unable to perform a straight leg raise should raise the suspicion, and X-ray will show the patella position alta or baja. The treatment depending on the available bone stock and chronicity of injury. And patellar maltracking, again a common problem leading to patient dissatisfaction following total knee arthroplasty, and one of the common reason for secondary surgery. And it is again will be seen when you are rehabilitating the patient. Clinically, it combines with anterior knee pain, patellar subluxation during ambulation, and there's a limitation of knee flexion. So the treatment may be operative or non-operative. Instability, again, you can see a gross instability here. So it can be due to early failure following total knee arthroplasty. So it can be diagnosed, especially clinically, with the varus valgus thrust during ambulation and positive posterior sagging in the 90-degree posture. So sometimes we need to go for a more constrained arthroplasty if this happens. So that can be detected while the patient is being rehabilitated. You will see these complications. So aseptic dosing is a long-term complication due to macrophage-induced inflammatory response, non-infective due to bone loss and implant loosening. So long-term rehabilitation, you might get these patients with instability, and when you do the X-ray, you can see this aseptic loosening. And treatment most of the time end with revision. And patellar trunk syndrome, again an interesting complication, which you see a painful palpable trunk when you do the movement, and usually a palpable pop or catch as a knee extend at around 40 degrees of flexion. And when you do the arthroscopy, you can see this the fibrous nodule scar tissues, especially in the posterior stabilized knees. And depending on the patient's symptoms, it can be observation or resection under arthroscopy. So joint stiffness, it's a common complication you all see following total knee replacement. So that is, we have to avoid things I have to avoid with proper rehabilitation. So the patient satisfaction and the functional outcome will be poor if the joint going into stiffness. So it's mainly diagnosed clinically, who have less than 90 degrees of flexion or a FFT of about 10 to 15 degrees. And treatment is, if you identify within 12 weeks, we can go for manipulation under anesthesia. But if it's more than 12 weeks, we have to go for adhesive disease, like arthroscopically or open, to get the flexion back. And heterotropic ossification, especially seen following surgery, Sometimes if you apply some Ayurvedic treatment, that will improve this, increase this presentation, where the bone formation in the soft tissues, which sometimes come with, can be diagnosed in the plain radiograph, and surgical excision is indicated only if there's a snapping or patellofemoral tracking difficulties. So reference would be these new technologies in arthroplasty and the AAOS comprehensive review and the orthopedics.com. And thank you very much for giving me this opportunity and for the listening to my lecture. And I had to rush through because my time constraint and all. But if there's any question, feel free to ask me during this time.
So, can you hear me, please?
Yes, I can hear.
Yeah, once the total knee replacement is done, it's like a new bionic joint. And also this joint surfaces, the metallic joint surfaces, you get wear and tear, and you get like micro metallic particles, over when you do many exercises, or if you just allow the patient to walk, or do anything, with a bionic joint, would it causes, later in life any problems with these particles remaining in the knee?
Yeah, it's can happen, but it's very rare in the knee. But this metal on metal processes we using for the hip replacement. Yes, there can be a lot of complications like LVAR and those due to these metal particles. But in the knee, there's a polyethylene insert always. We don't do metal on knee, so that complications are rare in knee. But yes, in hip replacement, there are metal on processes. There will be a lot of recognized complications.
Yeah, I have gone through, some articles about, like sarcoma, sarcomas and like that in the hip replacement.
Yes.
Not in knee replacement.
Knees is very rare because of the we always use the polyethylene, so the metal wear is less, but there will be polyethylene wear which can lead to this macrophages and lead into this non-infective loosening, aseptic loosening can happen. Yes, that can happen.
Thank you so much.
Yes.
Thank you very much, sir. There is one more question, sir. Shall I read it, sir?
Yeah, please.
Are there less chance of getting venous complications after robotic TKR?
Actually, venous complication, the handling will be precise, so there will be less handling, so the less trauma on the venous system. But mainly venous complications are mainly due to the patient's conditions, whether the patient had a previous DVT or hypercoagular state. But robotics might lessen the complications because the handling is less and precise, not like in a total manual handling of the stretching of the veins.
Thank you very much, sir. Those are the questions, sir. Thank you very much. It's more informative.
Okay, thank you very much.
Thank you so much.
Okay, So we are going to move to the next session. The next session will be on the topic of physiotherapy management for total knee arthroscopy. It is going to be done by Dr. Javin H. Bahat, certified kinetic control movement therapist and UK certified manual therapy for MTFI. Sir, it's over to you, sir.
Yes, thank you so much. Am I audible to everyone?
Yes, sir. You are audible to me.
Yeah, okay, fine. Thank you so much. Let me share my clip. Okay, fine. So I hope my screen will be visible to you, sir.
Yes, sir, definitely, yes.
Okay. Thank you so much for Sri Lankan Physiotherapy Association that inviting me to deliver the topic regarding total knee arthroplasty management. And so let's come to the topic regarding the total knee arthroplasty. In previous lecture, doctor has explained very well about how they are performing the arthroplasty, and they very enlightening us about the complication that we must know about during the rehabilitation strategy, as well as the incision site is also help us to identify regarding the quadriceps deficit and other things. So just giving a brief introduction. I'm doing a private practice since 2007. I'm a senior physiotherapist at ISRO. On the right side of the image that you are seeing, that I have written the book Anterior Cruciate Ligament, and I am the editorial board member of Italian Journal of Sports Medicine and Rehabilitation. Motor Learning Institute is my education partner. So let's directly deep dive into today's topic. The communication is important things, which is very important things for the surgeon as well as the physio. When the patient comes to our clinic after the total knee replacement at say about after 2 weeks or 3 weeks or so, then first of all, I would suggest to talk with the surgeon. What are the things they have done? It's all about the knee replacement, but if surgeon wants to go for a late or they wants to protect the knee joint, that is also important thing. So communication will help us to give a very good outcomes in a late stage rehabilitation, and that will help the patient to reach its functional activity. So communication is very important thing. The aim of the rehabilitation is to improve the activity of daily living, the knee range of motion as well as the muscle strength. We must improve the patient understanding through advice as well as education. Education plays a vital role in a total knee arthroplasty. There are certain literature says over the decades, we have to also go for the pre-rehabilitation. In pre-rehabilitation, we must educate the patient regarding the procedure, as well as we must understand, we must tell the patient about how they are performing the exercise after the knee arthroplasty. On the other side, patient wants to improve their activity of daily living. Before knee surgery, they fail to walk more than 500 meters or they fail to go for the stair climbing activity. So these are their routine activities. So we must focus on the activity of daily living. After the total knee arthroplasty, according to these researchers, they said that there is a large loss in a strength and function first 48 hours of total knee arthroplasty. The quadriceps strength has been decreased by 80%. If we have done the manual muscle testing before surgery, then it is very easy for us to understand how much quadriceps strength has been decreased. The walking distance is also decreased by 70%. There is a large loss in strength and function in first 4 weeks also at the post total knee arthroplasty. It is about 50 to 60%. They have done fantastic research in their demographic area, and they conclude that there is also activation deficit by 20%. There is also a walking distance which is decreased by 40%, and stair climbing speed is also decreased by more than 70%. So for those who are come to our clinic after knee replacement, Usually the age is in India, it's about above 60 years of age. But there are patients which I am looking, those who have done the replacement at the age of 45, at the age of 50, due to, as in the previous lecture said, about due to the deformity, they have any complex fracture and they are developing any arthritis. So we have to look from the strength perspective as well as the functional perspective also. We don't have to think about only the quadriceps deficit. Yes, in this is also a long-term deficit in a strength and function compared to the healthy adults. In a Bond et al. In 2010 in JOSPT, they have also told that the 40% deficit in quadriceps strength, that is compared to the healthy adult. The 30% is also deficit in walking distance, as well as 105% of deficit in stair climbing speed as compared to healthy adults. So from this literature, we must understand that when the patient comes to the clinic after the knee replacement, we must focus on the functional outcomes also. The quadriceps is the, I would say, it's a major component in a knee replacement as well as in lower extremity rehabilitation. So again, in Jill 2001, as well as other researchers said that there is also 90% substantial reduction in the pain after the knee replacement surgery. And that is number one benefit for the patient. Patients are in very excruciating pain. They don't even walk properly. And once they underwent the knee replacement surgery, the pain will 90% go away. I have also encountered with the patient those who have a complaint more than 2 months of pain, but that needs to be required education, as well as you can use another exercise as well as the modalities to subside their pain. So if you look at this graph, the quadriceps strength loss after total knee replacement, on the left hand side, the quadriceps strength, and the below healthy adults, as well as pre-op 1 month, 3 months, as well as the 6 months. If we compared the total knee replacement participants to the healthy individual, there is not much improvement in the quadriceps strength. There is the loss at the end of 6 months also. So if the patient continue with the loss of quadriceps strength, that is a problem in a gait cycle. Many of times patient is disconnected to the our clinic. Why function is limited? Because the patient don't have a pain, and many of times there is only a concentration regarding the range of motion. Once the patient gets full range of motion, fine. They got the instruction that you don't need to go for any other physiotherapy, or now it's okay. You are walking predominantly very normally. So that is the reason the patient is disconnected, and that is why patient has a functional in a range of motion. Different people have different thoughts and they have their own protocol. So this is about a general perspective. According to the Rebeb et al., they have find out the 34 type of different exercise, but in our clinical settings, we just follow this 7 type of exercise in initial stage. These are the standard exercise that we usually use in our knee rehabilitation protocol. We use squat, we use step ups, we use the straight leg raise, we use the heel slide. All these exercises are related to improve the range of motion, as well as a certain point of you can improve the quadriceps strength also. The passive flexion or extension exercise is also helpful. There are debates going on for initial stage of using CPM machine. It's also controversial. Many of them getting the results with the CPM machine for improving the flexion, but some of them are not gaining the flexion improvement after using the CPM machine. CPM machine is not improve the knee extension. So if you want to use the CPM machine, then you must discuss with the surgeon before implementing the CPM machine. Those who are those who underwent this revision surgery due to a certain complication, or then it is very advisable to go for CPM machine to maintain the range of motion, to prevent the stiffness. Once your muscles become stiff, there is a limitation in a range of motion. Eventually joint develops the adhesion because of muscles is not efficient to gain the full range of motion. So in that scenario, in initial stage, you can use the CPM machine. But again, I am telling you, take a note, discuss with the surgeon for using the CPM machine. And what should we focus to improve the outcomes? According to these two researchers, they said that quadriceps strength is directly related to functional performance. Therefore, quadriceps strength is much more focused for ongoing research. If your patient does not get enough quadriceps strength, he will not get the full knee extension. He has a problem in a gait, and once you will not improve the gait, still patient is telling us, when can I go for a long walk? Before surgery, he may walk for 1 or 2 kilometers, but due to pain, he may subside. But now the knee is new. So this is the very important aspect for the knee rehabilitation after the replacement surgery. Quadriceps strength is very important aspect. Is the mechanism of quadriceps strength loss is the simplest way. We are talking from the pre-existing quadriceps deficit before surgery. The acute strength loss, there is an activation deficit, and the long-term strength loss is convert into the atrophy. So when the person starts developing in arthritis, when he moves from grade 2, grade 3, and grade 4, and still he has a quadriceps deficit, he may have a long-term strength after the surgery also. So when you are seeing with the arthritic patient with the deformity, try to activate the quadriceps muscles as soon as possible. If you have a very short-term time, just educate about the exercise part. If you have a 1 week, in 1 week, we cannot improve the quadriceps strength. Just we can educate and teach the patient how to activate the quadriceps muscles. What are the things needs to be considered? It is not all about to contract the quadriceps muscles. When the patient is contracting the quadriceps muscle, we must look for one joint above. We also look for the hip joint also, whether the person is contracting the gluteus muscles or not. If he is contracting the gluteus muscles followed by quadriceps contraction, which is not is optimal activation of your quadriceps muscles. At the end of 10th or 15th day of your patient's session, still you may find there is a loss of extensor leg, because your patient is activating the secondary quadriceps muscles. First, he is using the gluteus muscles. So once you find out the quadriceps strength loss, we have to directly jump into the activation of a quadriceps muscles. So now how you can identify, these are the clinical battery of tests that I am using in my routine clinical practice. The quadriceps sets. After the surgery, if you are going into the hospital and you see the patient post-operatively second day, and you will not find any quadriceps contraction, you may mark it as a 0. You may find the poor contraction, but there is no superior movement of patella. It is very important thing. If you will not find superior movement of patella, you can mark it as a 1. A strong contraction with visible superior movement of patella is mark it as a 2. And the straight leg raise on the right side of the picture, this is a knee flexion with SLR. Many of times, due to pain, due to inflammation, patient may feel the heaviness in his lower extremity. So in that scenario, patient is unable to perform. You can mark it as a 0. Patient is able to perform with knee flexion. Many of times, patient go for the hip flexion on another leg, because he is compensating to complete the SLR with knee flexion. So in that scenario, you can also mark it as a 1. A knee extension should be about 2 feet of the surface. So if you use this clinical battery of tests, that will help you in your clinical outcomes. You can tell the patients about his performance. Initially, when he comes to your clinic, he is not able to perform. You have marked it as a 0. After 15 or 3 weeks, you can reach up to 2. So this will help you to improve the quadriceps set, as well as it will educate the patient to reach its functional goal. Now about extensor leg. In previous lecture, doctor had said about there is an insertion type. In that, he said there is an extensor leg maybe remaining. Okay, but many of times surgeon will not prefer. They don't want an extensor leg in their patient. Before surgery, patient has a quadriceps deficit, and after surgery, he is developing the quadriceps deficit along with the extensor leg. So how to correct the extensor leg? What are the things needs to be considered to get the full knee extension? If you don't get the full knee extension, you will not get a proper pain. There may be a joint stiffness due to the muscle weakness, or person may have a joint distension. These are the 4 things that may be the possible cause of extensor leg. We must subside the pain. We must subside the inflammation in initial stage of rehabilitation. If you find out the joint is too much distension, you can communicate with the surgeon, and according to his advice, we must follow the rehabilitation protocol to subside the pain as well as the inflammation part. These are the steps to find the person has an extensor leg. It's the simplest way. You can clench a fist under the patient's heel so that the extremity was clear of the table. So when you ask the patient, when you see the patient in a supine line, you may find there is a 5 degree or 10 degree of extensor leg. When you clench a fist under the heel and patient make the knee in a straight line, that is the indication person has extensor leg. You can ask the person to tighten the quadriceps muscles by pushing his knee down towards the table. If he fails, that is the indication he has a problem of an extensor leg. The person has not enough to contract the quadriceps muscles. As I said in a previous slide, person fails to contract the quadriceps muscles and failed to move the patella superiorly. That is also a sign of extensor leg. As well as in extensor leg was detected when the knee did not remain fully extended. The classical signs which I want to tell you about, when you ask the patient to go for knee flexion followed by knee extension, at the last 30 degree, patient will rotate the knee, internal external rotation of a lower extremity, and followed by he reached to the full knee extension. So that things must be understand. So this is the classical signs that we must look for the extensor leg. So for the prevention, there should not be a knee flexion during SLR. Dorsiflexion plus quadriceps contraction, that must be gained, because that is the sign of an heel strike position. When you ask the person to go for heel strike, there is a dorsiflexion followed by knee contraction. Before going to the off table exercise, there should be a proper control of a knee joint on an on table exercise. If you don't have a good control of a quadriceps as well as a knee joint on table, you will not get a gait cycle, a fully gait cycle. Again, ankle range of motion, that is the very important thing. If you find out person has a loss of ankle rocker, due to the loss of ankle rocker, you will not get a hip extension on an ipsilateral side. If the person has a right side knee replacement and he is not getting a dorsiflexion, the person will not get the same side hip extension. So to gain the knee range of motion, which is very important scenario. Excuse me. So for gait re-education, I would say quadriceps is the king. On the right top of the side of the picture, the heel strike requires a full knee extension. If the person has a full dorsiflexion, he will reach to the hip extension on a ipsilateral side. If the person don't have a good ankle rocker, he starts limping. Opposite side has a problem in a hip extension also. Okay, so we have to re-educate the gait. When you ask the patient in a sitting position to go for knee extension, many of times patient move the pelvis posteriorly and gain the full knee extension. He fails to make his lumbar spine straight. So that is the thing we must look for, gaining the full knee extension. On the left hand side of the picture, the patient is sit erect and he has a very good knee extension. The another simplest way to understand about when patient is gaining full knee extension, the knee should be parallel to the ground. Sorry. If the tibia or a fibula is not parallel to the ground, just check from the lumbar spine. Make the person's spine straight. You will find out your answer. So these are the things that we must understand for the gait re-education. Now I will show you about how to activate the quadriceps muscles. Okay, sir, can you give me the permission on my opposite ID for camera?
Which one, sir?
Just wait a minute. Let me check from my setting part.
Okay.
Okay, fine. Just I will start from here only. So when you want to improve the heel strike pattern compromise with the
Hello, sir. Your mic is muted, sir.
okay, fine. Okay, fine. So if you want to improve the quadriceps muscles firing, the person comes with a limping gait. You can start with a neuromuscular stimulation to the quadriceps muscles. Along with that, you can place a hurdle on the floor and you can ask the patient to go to do the heel strike pattern. In a heel strike pattern, you must look for the patella should contract superiorly. That is the important way to get the heel strike. You can ask the patient to do repeated motion. Heel strike, then again he can place your foot, he can place his feet behind the opposite leg. He should touch the great toe and then make the knee into the extension phase. This will contract, this will enable the quadriceps to contract. Again, you can teach the patient to the same way. It will initiate your quadriceps muscles. On the other side, You can also ask the patient go for the step up and step down. When he go for step down, you can place the patient's foot by the side, because when the patient go for step up and step down, the knee has to be locked. This is also the another way to improve the quadriceps muscles. The third way to get the quadriceps muscles activation in a sagittal plane, you can also ask the patient to go for hip extension. Hip extension, it requires a knee extension, because when you go for opposite leg into the stance phase, it goes into the stance phase, the opposite side, the right side will go into the extension. Okay, so in extension, it requires the knee should be in a extension position. So this is the way you can step up and you can go step down. So these are the three things that you must understand how to improve the quadriceps muscles in a sagittal plane. This will help you very well. I'm not telling about start the backward walking, because it might give a painful. On the other side, you can also ask the patient to go for a standing hip abduction with the knee locking mechanism. All these exercise you can continue with the neuromuscular stimulation also. Before going for the quadriceps activation, you can also go for the little bit of calf stretching. Now, to improve the ankle range of motion, as we all know about the knee to wall exercise, knee to wall exercise works very well, but in patient, if he has a 90-degree of range of motion, you can use about 3 feet stool. Okay, just I am showing over here on a chair. This height should not use for your replacement patient. Just this is for the demonstration purpose only. So place the patient's feet on a small stool around 3 to 6 inch high. You can ask the patient to gently rock forward as well as backward. Gently. He or she should not feel pain. By performing this exercise, there should not be a knee valgus. When you are performing this exercise, there should not be a knee valgus. Knee should be in a sagittal plane. It should not go out of the sagittal plane. So by doing this exercise, it will improve your ankle range of motion, as well as it will improve the proprioception also. So this is the very simplest way to activate the quadriceps muscles in a sagittal plane. So now you have reached to the certain goal to your patient. You have cleared the gate. Now patient is walking very normally. He doesn't have any pain. He used to walk more than 1 kilometer. Okay, but still stair climbing, step up and step down. He is not that much satisfactory. So what is next? What are the things that we must include for this type of patient? We have to start reloading. When your patient has an asymmetry, previously I talked about patient is walking very normally, but if the patient has a problem in a walking, or if you find out the person has an asymmetry in a descending stair, he has to take a support. When he is going into the sit to stand position, he or she needs to take a support. In that scenario, we must find it out whether the person has a hip strategy or the person has a knee strategy. This type of sit to stand position, the person, let's assume patient has a right side replacement. This type of sit to stand activity increase the hip recruitment. There is a decrease in quadriceps recruitment. the weight shift towards the unaffected side. When the weight is shifted towards unaffected side, the right side take a less load. Many of times our patient has a catastrophizing for the movement part. They have a fear of movement. They feel that after operation, we should not take a too much load on the operated side because it might get injured. But we need to educate the patient in such a way that he should or she should take a load, because when he starts the stair climbing, it requires the load first. The loading mechanism requires the first and important thing. You must decide the dosage of a load with the limit of a VAS, a visual analog scale. If you want to improve the load on the patient right side, as I told you earlier, you can start with the step up, step down on an opposite leg. So right leg will stay on the ground. From left leg, you start the step up and step down. So what will happen? That is creating your mid stance position of an affected leg, and the left leg will go in a swing phase. Okay. So all the exercise should be mimicked in your gait cycle. So likewise, you can start with a loading pattern. Okay. So if your patient has a pain while performing the loading activity, that pain should be subsided within 3 to 4 hours or maximum 24 hours. On the next day, if the patient said that in morning, I feel some kind of stiffness, or I may feel a certain type of pain, that clearly indicates we must subside our dosage, our frequency, as well as the volume of an exercise. You must subside the repetition, you must subside the patient's activity level. If you find out after 24 hours, patient complains of pain or stiffness, if the pain subsides within 2 to 3 hours of your session, then it is okay to move further on your routine protocol. It indicates that you have done fantastic job and your patient is pain-free. So these things that we must understand about to improve the load. You can use many other techniques also to improve the load of an operated limb, but this load should be given once you have a full knee extension. If you don't have a full knee extension, don't start the loading program, because person may start knee buckling. As the surgeon said, there is a complication of a patella tendon rupture in a rehabilitation. If the person don't have enough quadriceps strength, and if you start going for a stair climbing, step up and step down exercise with full load, they might have a rupture of a patella tendon. So go very gradually in your rehabilitation plan. There should be a role. There should be a goal. Within 2 to 3 months, the person should reach to his original level. Now you have cleared the load pattern. You on the other side, you can also you have a very good gait cycle. You can also add gym ball activity, as well as you can also ask the patient to stand on a wobble board to improve the symmetry on the both leg with support. Without support, don't start any exercise, because they need a support. They have a fear of fall. They have a fear of losing the balance. So these are the simplest way of exercise that you can use to improve the load. Now, we are moving further from improving the range of motion. We don't stick to the only improving the range of motion, only improving the quadriceps muscles deficit. This is the fantastic literature. The randomized control trial has been done in 2020. The method, they took the 40 participants from January 2017 to June 2018 in a high intensity group, and second one is low intensity group, the conventional therapy. The age bar is between 50 to 60 years of age. They have an exclusion criteria for those who have a malignancy, those who are in a hypertension, CVS problem. They excluded this patient. they divide the high intensity exercise in a 4 phase. In a phase 1, initially, they go for hill slide, they go for a calf stretch. As the phase increase, they, in a late stage, they go for a single leg calf raise exercise. They have decided specific reps and specific set, and they have a specific criteria. You cannot move to the second criteria if the VAS scale is about 7 or 8. If the patient VAS scale is 7 or 8, you should not move. The VAS scale should be around 3 to 4. In the result, they find it out that those who are into the high intensity training of exercise, they have a very less time in a stair climbing at the 3 months as well as the 12 months. As well as they have a reduction of time in a 6-minute walk test, as well as they have a less pain according to the VAS scale. So the high intensity exercise is superior, and we must implement the high intensity exercise in our rehabilitation regime. Again, in this paper, they said that at the 1 month of follow-up, they find it out there is a significant difference in a 1 month follow-up as well as at the 3 months of follow-up. In 3 months of follow-up, if you look at the stair climbing test, a time up 6-minute walk test, there is a significant change in the test. Again, this is the systemic review and meta-analysis, the PubMed and Cochrane review. They have 18 RCT. They have find out more than 200 papers, but 18 RCT are fit into their category from the Prisma scale. The result is from pain, range of motion, there is a heterogeneity for the rehabilitation protocol. There is no clear pattern in combination of starting time of rehabilitation. Some researchers start their rehabilitation program on a second day. Some have started after 4 weeks. So there is no specific time pattern for duration of rehabilitation. And that significantly increase the clinical outcomes. And there is no specific method to improve the WOMAC scale. The TUG, the time up and go test, 6-minute walk test, the starting point of rehabilitation doesn't seems to be very effective. If you start a rehabilitation at the fourth week and you compare the 6-minute walk test and time up and go test, there is not significant change according to this literature. So from this literature, we can conclude that if you start your exercise plan, if the patient comes to your clinic after 4 weeks of surgery, and if you think that you have to improve the 6-minute walk test, the time up and go test with a less number of time. So we must understand there is no clear pattern of combination of starting point. Again, this is a very fantastic paper. We must implement the sensory motor training to our patient. In this paper, they said that there is improvement in a functional outcome at the 14 weeks. They have improved the Tai Chi, the balance, the another sensory motor training part. And if you look at this graph for the rehabilitation perspective, for the x-axis representing as a time and the y representing as a peak force. The dotted line is for the non-operated limb, and the clear black line is for the operated limb. So when they have implemented the sensory motor training at the 2 weeks, they have found a substantial increase in the force of a quadriceps muscles as well as in the lower extremity, as you can see. So we must start with the sensory motor training. Once we gain the full knee extension, you can add up a changing of the surface. You can add an unstable surface in a once the patient finds a smooth exercise, you can add a different type of surface. At the 14 weeks, from 2 weeks to 14 weeks, there is a very consistency increase of outcomes as well as in a muscle strength. a peak force of a muscle strength. So sensory motor training, we must implement in our rehabilitation program. The patient has a problem catastrophizing of a movement as well as fear of fall. The patient has a fear of balance. When the surgeon did the surgery for the knee joint, when they go for the knee replacement, they just cut the capsule. There is a disruption of A alpha as well as A beta fibers. So we must improve the proprioception. As in a previous lecture, they said about the PCL ligament, they improve the tension of MCL as well as the LCL. There is a less chances of working on a proprioception, but there are certain literature, they have find out there is a less tensioning of MCL, LCL as well as the PCL ligament. They have a more fear, or their knee joint goes into the valgus or in varus. They feel unstable while walking. So the balance perturbation task can be more targeted towards the frontal plane provocation and less in sagittal plane. And balance exercise with eyes closed should be performed. First, you can check, you can assess with the eyes closed. If the person has a too much problem in a balance, then you can start with the eyes open exercise. Lateral step up and hurdle walk will give us a very good proprioception as well as the balance exercise. The hurdle walk implies, as you can see in this picture, it's your single leg stance position. The opposite leg goes into the swing phase. So the operated side limb take a load as well as it improves the proprioception. Take a note, to improve the proprioception, there must be a full range of motion and there should not be a pain. So these two exercises you can implement in a knee arthroplasty patient. So from this take-home messages about quadriceps muscles dysfunction after total knee arthroplasty serves as a model to understand there is a deficit from any number of other MSK injuries. Muscles activation deficit plays a substantial role in strength loss with a trauma and should be considered in conjunction with other intervention strategies. Start with the neuromuscular stimulation from the second day. Okay, if surgeon permits, reduce the pain as well as the swelling. That is the important criteria. Focus rehab towards the patient goal, what the patient requires. Yes, after replacement, he can walk. It is not his goal. Ask about his functional activity. And the last and foremost important thing, one size doesn't fit for all. Don't stick to the simple protocol. Don't marry to the single system. Think out of the box. Every patient is a different book. One patient has an extensor leg, second patient does not have an extensor leg. So you cannot stick to the same protocol for each and every patient. Thank you so much for listening to this lecture. This is my two upcoming books. The anterior cruciate ligament is brain-based rehabilitation, and the second one is the shoulder joint. And just giving you an idea about, this is my protocol that I have evolved a movement. I have took the 5 pattern of movement from the fundamental base. On the left hand side, the round circle which you are seeing, that I have created a mat that you can assess each and every joint dysfunction on this mat. If you want to assess the trunk extension, yes, it is, you can measure. If you want to assess the single leg hop, you can assess. So this is my movement evolve for you people. It will come in a soon stage, and this is my philosophy of a movement. I spot the movement signature, movement habits and behavior, change the intention. You can see this philosophy of movement on my YouTube channel, Proactive Physio Knowledge. That is my YouTube channel, and you can reach me on Instagram at @proactive_physio knowledge. This is my website. Throughout this lecture, as you can see on the left hand side logo, that is Proactive Physio Knowledge, and this is my email that you can reach me if you have any questions. Thank you so much for listening, and again thank you Sri Lankan Association of Physiotherapy to give me the opportunity to share my knowledge regarding the knee arthroplasty. Thank you so much.
Thank you very much, sir. It's very knowledgeable and it was very useful for us. There are a few questions, sir. Shall I ask it, sir?
Yes, sir, please.
The first question is how to improve range of motion of knee with minimal pain if the patient had stiffness?
See, this is very important thing. When the patient has a stiffness, there is always a tug of war is going on in the patient. Patient may have a problem in a knee extension. That is the one scenario. So in that part, we have to improve the hamstring muscles activity. By giving the hamstring muscles activity, you have to mobilize the hamstring muscles. Okay, start with the high sitting exercise, go for the auto assisted, then followed by the supine exercise. Okay, for minimal pain, we have to check for the dosage, how much patient is applying the pressure when he wants to do the knee flexion. Don't start with the supine line in initial phase. There are a different approach for the surgeon, but usually from my point of view, I usually start the knee flexion in a sitting position. Eventually you can give a skateboard to improve the knee flexion. It will improve the hamstring activity as well as it will stretch the quadriceps muscles. So likewise, you can improve the range of motion.
So the next question is, sir, after how many days we start patella mobilization?
Not days. I would suggest if the surgeon has done the surgery in the morning, from evening, you can start the patella mobilization, or from the second day, if the pain permits.
Okay. So the third question is stair climbing good or bad for knee osteoarthritis?
For knee osteoarthritis, it depends depending on the stage of in which stage the patient is fit. If the patient has a grade 2, you can go for the stair climbing. If the patient is into the grade 3 and grade 4, you can ask the patient to go for stair climbing, but you need to modify them. Don't give a too much load on that angry knee. It is already angry. There is too much of swelling. There is too much of synovitis. Don't give a too much load for that patient. You can modify the stair climbing pattern and you can advise the patient to go upstairs.
Thank you. Thank you very much. Sir, there one more question, sir. Can we do cross leg sitting after 6 months of surgery?
See, this is the for this question we must communicate with the surgeon. It is depending on the joint, how the surgeon has used the joint. If he is using the 360 degree of knee implant, yes, we can go for the cross leg sitting. But surgeon told us you can start with the cross leg sitting and still patient fails to gain cross leg sitting, then we must check for one joint above.
So there's one more continuing question, like how to modify stair climbing, sir.
How to modify stair climbing? Initially, you can start with the low height. Okay, you can ask the you can start with the step up, step down exercise in a very low height. Ask the patient to go on a low height step up. From that, he will go down. So what will happen? You are working in a less knee range of motion. If usually in India, there is about a 6 to 7 inch height of a step. So what I usually do, I cut it down 50% of the step height and train the patient in that scenario. If the patient has a too much pain, I will ask the patient, don't go for stair climbing until and unless the pain subside. So you can cut it down the height of a stair and implement your patient.
Thank you very much, sir. Those are the questions, sir. It's a very wonderful and knowledgeable session, sir. Thank you very much, sir, once again.
Yeah, thank you so much.
Okay. So now we are going for move. We are planning to move to the next session. Sorry, because due to some connectivity issues, we try to change our schedule, but our resource person are back again. We sincerely apologize for the difficulties and inconvenience. Now we are moving for the fifth session as in the agenda.
Our next lecturer is Professor Manish Arora. Professor Arora is the Dean of Student Welfare at the Sardar Bhagwan Singh University, Dehradun, India. He is the Senior Consultant of Your Physiotherapy Clinic and the Director of STEM Rehab, Dehradun, India. He is a member of the Regulating Committee of Physiotherapy of the University Grants Commission of India. Professor Arora is not only a specialist in physiotherapy, but also a specialist in osteopathy, with more than 22 years of teaching experience. He has conducted more than 50 extended lectures and workshops all over India and supervised more than 200 undergraduate and postgraduate dissertations. He is an external examiner at 25 universities. He had presented and published more than 130 papers in various international and national journals. Professor Arora, a specialist in manual therapy, developed new concepts like dry needling in kinetic release and rapid manual scans for muscle dysfunction. He was rewarded with 6 national level awards, including the Physio Ratan, Jewel of Physiotherapy, and the Best Academician Award. Without further ado, I cordially invite Professor Manish Arora to deliver his lecture on drop table technique and osteopathic manipulation therapy for knee osteoarthritis.
Thank you, ma'am. Indeed, it's a great pleasure for me to be here on this platform of Sri Lankan Physiotherapy Society. And I'm humbled by this invitation by the President, Secretary, and my dear friend, Dr. Vasanta, to be here on this platform. Let me share my screen. Please give me a second. I hope you're able to see my screen.
Yes, sir. We were able to see you.
Thanks a lot. I'm going to talk about the manipulative therapy in osteoarthritis. It may be a little out of the box thinking in terms of what we physios have been doing all these years. But then everything adds to our abilities. And with this effort to augment our abilities in treating and not only treating but preventing osteoarthritis, this little presentation is there. I've been already introduced by the worthy coordinator. So I'll skip these slides which were lined up. I've been trying to learn osteopathy, though my technical skills started with my master's in physiotherapy, but of late, I've been trying to add up more and more into osteopathy. And why so? Because every little tool is important when you're working as a clinician or as a workman. Osteopathy definitely is another booster, but not at the expense that it is a substitute what we have been doing all these years. So it adds up to our ability as a physiotherapist to what my predecessors have talked about. And this little effort is to mix the concepts because human body does not get divided into the domains of osteopathy, physiotherapy, or chiropractic. It only has our ability to work normally, which we call it as physiology. It has got its own structural ways of working, which we call it anatomy. And these all techniques, or these all branches of manual therapy should work together in trying to restore the function of the human body by correcting structural faults. The problem is we always think manipulation is just about giving a few cracks. Actually, it is not true. And it can be very dangerous if it is done without any proper diagnosis or proper evaluation. The world of manipulative therapy is not just creating those pops, because those pops are those high velocity thrusts which bring the changes in our structures actually are at times not doing the effect they want to create. Most of the times when you manipulate a joint, it may occur at a joint which is already moving nicely, but not at an area which is hypermobile. So we want to find the exact thing and then work on it. And before I go into that domain, let me tell you, we have to understand that pain and dysfunction comes from various reasons. If I have inflammation, I would definitely like to use ice and inflammatory controlling mechanisms rather than doing a manipulative therapy. A patient may have pain because he may be only recruiting his particular muscles because creating some tension. And this could be because he has a psychosocial issues where the tension in the muscles is creating an imbalance. So there, I may need to work differently. But if the patient comes with a biomechanical dysfunction, this kind of talk which I'm doing is going to be more suitable for those patients. We all know our joints have an ability to move in a controlled manner. Neither overmobility in this joint, which is called as hypermobility, or lack of mobility in these joints, which is called as hypomobility, are good for the joints. And again, the hypomobility or lack of movement in the joints can come because I have a problem in the capsule of the joint where there's an articular fixations, where the drops and these mechanisms are going to work. Whereas I may have a person who is not able to perform the full range of the joint because the myofascial elements do not work. There are techniques like myofascial release, or what we have developed, a very active and precisely controlled way of releasing the fascia, which we call as myokinetics, works. Similarly, in an unstable joint, I will require some fixations, or in a joint where there's a burnt of generalized hypermobility in the body, I may require techniques like kinetic control, Pilates, or other things. We all know this chart. Hypermobility can be from no movement of ankylosis, where the joint is used. I'm not going to get any purchase out of these techniques. Then I have a considerable decreased movement, which may be because of gross degeneration, where I may have a limited role in getting the restoration of function. But when hypomobility comes because of lack of joint play, my techniques are going to be the best useful techniques in that. Of course, hypermobility, this is not the cup of tea. Now, these kind of fixations, which we call the lack of joint play, come from two different reasons. In today's world, the biggest cause is myofascial imbalances, and the second cause for this is trauma. So if a joint is used in its optimal position, the structures on both the sides stay balanced. But if I use asymmetrically, one side muscles will definitely become more powerful, pulling the joint away from its axis as compared to the other side. That is where I will have an issue with the joint losing its ability to be symmetrical. And over a period of time, maybe years together, the joint may also get misaligned in one direction and get struck in that direction. And then the problem of this lack of mobility contributes to further deterioration of the joint. So if my myofascial elements are good, the joint stays healthy. But if the myofascial elements are tight, what will happen? They'll pull the joint out of its alignment. Like this, the myofascial element shown by the orange arrow is now becoming tighter, and it puts the joint out of its alignment, creating a friction between the articular surfaces, damaging the articular cartilage. Still worse, sometimes my core strength does not allow the joint to go out of alignment. I shouldn't be happy about it because this orange arrow again, which is now becoming tighter, representing the myofascial tightness, now is going to create a pull on the periosteum and drag that periosteum, leading to osteophytes and spurs. And this is how the dysfunctions all begin. So, as we know, the car tire would last longer if it is aligned on its wheel. Previously, osteoarthritis was said to be age-related disorders. Anytime, if you drive the car for, say, about 90,000 kilometers, will wear out. Any knee will start wearing out with age, but the biggest culprit is not the age. We have seen people, and you must have seen people, who are 80 years and they do not have any problem with their knees. But there are people with 40 years who have a lot of problems with their knees. So alignments are said to be the bigger offenders. And that is why osteoarthritis in an X-ray is seen by its asymmetry. If both the sides in an X-ray show degeneration or reduced joint space, we rarely blame it to osteoarthritis. A bilateral reduction in space, maybe because of rheumatoid arthritis, where the penis encroaches this thing. But in osteoarthritis, normally it's a one side more than the other. So why this degeneration will occur? A joint in a healthy state breathes easy. It moves up and down, the bones relative to each other, and they are not fixated. Now, such a joint has good synovial sweeps so that the little damage which may occur is easily repaired because the nutrition comes from the synovial movements. But when the joint gets misaligned and it goes into the plastic zone, as said by White and Punjabi, rather than staying in its elastic zone, it gets struck. So not only the joint has a poor alignment where there's a rubbing of one area, but the lack of synovial sweep makes the joint less able to repair itself. And this is where the problem begins. So what we need is to ensure two things. Not only we restore the correct alignment of the joint, but we restore the mobility of the joint by getting it back into its position. So that is what our aim is. One important thing which I picked up from the work of Robin McKenzie, though he talked about in his book on back pains, but is very pertinent to all the joints in the body, is the self-limitation of problems. What happens when we get an initial pain? If I have a misaligned joint, it may create a little inflammation. By medicines, or not even some medicines, the pain will go away in a few days on its own. That's what Robin McKenzie said. About 44% of the patients with low back pain will become better in 1 week on their own without any intervention. 86% of them will become better in 1 month, and 92% within 2 months without seeing any therapist, chiropractor, physician, anybody. Because the body has an ability to mask its own dysfunctions. And that is usually done by some compensatory changes. Now let's apply this thing on the knee. If I have a reduced medial joint space, as you can see on this X-ray, my body will try to get me out of pain by overactivating the muscle on the lateral side, like the tensor fascia lata and the iliotibial band. Now, when the tensor fascia lata or iliotibial band, which attaches on the Gardy's tubercle on the tibia, pulls the tibia more upwards, the space on the medial side is made better. But what will it result in? It will only result in creating a bicompartmental osteoarthritis with passage of time, with the dysfunction not longer staying just to the medial compartment, but across dysfunction of the entire joint will start occurring. And this is where a little problem, which could have been resolved early, now becomes more devastating, and we are left with no options but to go for more aggressive methods of correcting it. And how to further understand that, many times when we have a nice carpeted grass, certain weeds grow up. And that is what happens with the initial aches or pains in the body. But when we neglect that, or we just try to cut that weed rather than removing the roots of the weed, what happens? The dysfunction inside keeps on growing like the roots, but we feel temporarily better. So the painkillers and pain inhibiting substances actually are not doing any good, rather than it is burning that fire which is hidden from outside, and we feel good about it. So over a period of time, with poor exercise and lack of proper treatment, these weeds keep on growing and they spoil the entire area. Like this garden, the joint also goes into severe degeneration. And by the time everything is lost by our hands, all we now require is to take away all the right and the wrong grass and regrow it. And that is what we call, in our terms, replacements. So the God-gifted nice joint has to be now replaced by an artificial joint, which I'm very sorry to say is not even 50% capable of doing those things which a normal joint would have done. So this is where the problem actually is keeping on growing. My objective is not just to try to treat those patients who have still some abilities left to self-heal themselves, which is maybe a grade 1 osteoarthritis or grade 2 osteoarthritis, but also my bigger challenge is to prevent that. One of my teachers from my medical college where I studied said osteoarthritis starts developing in 30s. In 40s, we realize that something is there inside our body. At 50s, we get in trouble. And 60s, we are no longer having osteoarthritis because steel does not have osteoarthritis. It is by the time replaced by artificial joints. So that is what we want to do. So if a patient comes to you, we are not only responsible to get that little ache or pain controlled by our IFTs, ultrasounds, and other things, but also we need to restore the myofascial health. We need to make the joints play restored. We need to ensure that none of the myofascial elements are tightened. So this is what has been seen. This is a rectification of what Mackenzie did in his book. We get pain and dysfunction when some stress comes on the joints. I'll get a knee pain only if I'm doing more miles than I've been doing, or I'm suddenly climbing more stairs or squatting more. My body was capable of managing my function abilities without giving me trouble. But when I overloaded it, some triggers get formed and I get the pain. And as a result of the pain, I go to a doctor, and if he just gets rid of my pain, which is wonderful, it is his job. It's the job of a therapist to reduce the pain. But if it doesn't restore the structures back to what they should have been, over a period of time, this will, with same stress, it will grow into a bigger pain and bigger dysfunction. But if you, while treating this pain, also restore the myofascial and the articular balances, this thing is less likely to come. And that is where we need to identify and correct those structures. Our objective is not just to restore the increased pain back to normal, but also get the joint perfectly aligned and suited so that both the function is restored and the pain is brought to normalcy. That is what the entire aim is. We need to find the directional fault, because if we are not finding the directional fault, we may be wrongly correcting it. So if the bone aligns in a different direction, I have to do it in a different way. I have to use different X's, I have to use different planes to correct this kind of fault. Now, I have very many options I have options which probably a good manipulative therapist or a chiropractor would do, which is a joint manipulation. I have options of Mulligan, which repeatedly I do the right directional movement and reposition the joint. I have Maitland, which again, by repeatedly pushing in the right direction will correct me. So all of them have their advantages and all of them have some disadvantages. So I want to add something more to that. Normally, if I am going to go for a manipulation, it will have a risk of maybe sometimes crossing this paraphysiological space and breaking the ligaments if I go into the anatomical barrier, because these manipulations are always short lever but high velocity, low amplitude. So the amplitude is very less, but I need very high velocity. It's just, I find where, see, I find where the fixation is, and then I pull it out. It's just like this braking system. I go at a very high velocity and suddenly stop. So the advantage of this manipulation is that in a very quick manner, rather than multiple repetition sessions, which are required in Maitland, I get the joint restored back to its normal position. But the danger is, if my brakes are not applied on time like this, I may have an accident. So to overcome this and to make the manipulations more safe, the drop techniques have been felt to be very, very useful. And that was what I thought that I may just put a little word about these things. These drop techniques can be easily learned, are more safer and more surer, because this is what can happen with the manipulation. Because you're doing a high velocity thrust, you may not control it and may end up in something which you never intended to get back. So with drops and these kind of devices, which now in physiotherapy world are called as physiotherapy instrument for mobilization, we can open the joint and create it better. So this is a real-time MRI picture, a dynamic MRI. If you see this dynamic MRI, I don't have something on the knee, but I have a thing to show you on the upper cervical spine. So you could see the C2 spine, which is obviously the first large structure to palpate. And there's an atlas in between and the occiput. So if you see here in the image, you can see how the joint, when fixated, is moving together. The C2 and occiput are moving together. They should have moved independently. So when they were treated by the instrument adjustments, this is what you're going to get after the treatment. Now, if you see out here on the right side, you could see the joint opening and closing, but on the left side, you could see, which is done before the adjustment, they're moving together. So that definitely says that it's not a myth that adjustments do not correct the fixations, but rather they are a real-time corrections of these fixations. And remember, These fixations are not on the area only where you get the trouble. For example, in osteoarthritis of the knee, these fixations could not just be on the knee itself, but they may be coming because my navicular bone may have fixated superiorly. So when my navicular bone gets fixated superiorly, my arch is going to stay high. I'm not going to get that cushioning of my arch. I may have a more chance of developing medial joint osteoarthritis for two reasons. One, that springing power or that safety factor which comes with my arch going up and down, which is more like a piston in the car, which gives you a shock prevention, is not working. And secondly, when my joint is at the foot, the metatarsal joints are going to stay supinated. I will have an increased external rotation of my tibia, and this will create a more damage to my knee joint. So before I go to the area where I need to fix it, I need to check the distal joints, maybe sometimes even the proximal areas, like not necessarily it's just the fixations. I may have a pure autonomic control coming from the spine, or it may be because a pure neurology may be coming from an L3 fixation of the vertebra. So in osteopathy, we work holistically. We are not only confined to the area where the problem is, but we work on the areas which are all concerned with the normal movement of that. So I may have a problem in this spring, but I need to work on the structural movement spring. So that is very important. Now going to the osteoarthritis in the knee, in the medial compartment, as I said, I'll first correct the spinal subluxations, sacroiliac fixations, hip fixations, and ankle fixations, and also check the neurological connections at L3. But then I'll work finally on the knee joint itself. I think globally, but also act locally. That is the motto of osteopathy. So what kind of fixation do we have? See, our joints are not of equal size. Inherently, there is a chances of one joint, that is medial compartment, getting more overloaded than the lateral compartment. Why so? Because we wanted a knee to get locked when we stand. The sizes were unequal, and there's always a coupled motion in the knee of rotation, which occurs with flexion and extension. And that is why we have three kinds of common misalignment in medial compartment of osteoarthritis, which is more done with genu varum. So I'm going to have more likely laterally fixated tibia, externally fixated tibia, and posteriorly fixated tibia. If you see, this is an X-ray on the figure 2 of a patient who is having a medial joint osteoarthritis. You could see the tibia is tending to move laterally. It tends to go externally rotated, and it tends to move posteriorly because most of the time our posterior structures like the medial hamstring, the gastrocnemius, they tend to be more overworking. So we tend to get these kind of things. And this is not just the belief of osteopaths, but if you have read Brian Mulligan, it says for medial knee pain, you have to glide the tibia medially. That means the tibia, in most of these degenerative osteoarthritis cases, is shifting laterally. So we need to identify first. My previous speaker said one wonderful thing. Every individual is different. We cannot have preset protocols. We need to tailorize. So we need to find the faults and we need to correct the faults. I need to find if this external rotation of tibia is there or not. we need to verify by biomechanical marking motion joint play. I have to check if my joint is externally struck, it will not easily move in the medial direction. It can be seen with the Q angle, can increase the crepitus, and I need to find it. Once I find it, I will correct it either by using Mulligan, Maitland, high velocity thrust as seen in this image, or by these drops. So how these drops are being done, you can see on this little video. Now if you see, this, if it is externally struck, I've used one little drop here. I need not to have two drops. I can only do with one of these drops. But since I'm not in my home place and I have to do it this outside, I didn't have appropriate size in terms of thickness, a wooden piece or something which I could keep it here. So if I don't keep something below the femur, that can create a little hyper extension of the knee when I'm trying to thrust. So I need one little block of wood, maybe a couple of books to stabilize this femur. Then, once I've done this, I keep this drop loaded. Now the drop is loaded by a lever, which you can see here, and the weight in the drop is adjusted by the black round knob. So I find the fall, and once I have found I want to do it, I thrust it with this drop piece. So the general group of the drop mechanism is you have to thrust it 3 times. And since it's a webinar, would have been live, I would have showed you that with motion testing, we would have found the tibia to be externally struck. Once I have treated with the drop, it immediately shows an improvement in the motion. So this is for the externally struck tibia, which is part of the 3 common alignment falls which you have. The second is a posteriorly translated tibia. The tibia normally would be restricted in the translation with the ACL and PCL ligaments, but a couple of millimeters posterior and a couple of millimeters anterior could get it struck anterior posteriorly. If it is not believed to be that, then why are we giving Maitland where we give a to P glide when I have a lack of flexion? So it's a confirmed thing. For flexion, we give a to P glide because it's struck anteriorly. For extension, we give a P to A glide because it's struck in extension. So same thing we could do with either giving a manipulation like this or using these drops. So these drops, now again I'm using for correcting the posteriorly struck tibia. So if you see, I'm placing the tibia on the drop and the upper side is not fixated because on the drop, I drop my hand on tibia, which is going anteriorly, only by thrusting the femur posteriorly. So if the femur is thrusted posteriorly, automatically it will create an anterior directional pull on the tibia. So this is how I correct it. And then, very important but not the last thing could be a correction of a laterally struck tibia. So if tibia is struck laterally, it will still create and maintain the fault. So how will I manage this? I can give manipulation here. I can use Mulligan, as I said, or I can give thrusts in various directions, or I place the patient in a sideline position and try to achieve the drop. Right. So that doesn't end my work. Of course, I need to rebalance the muscles like VMO, because if they won't fire, I won't have a stability. I need to correct the soft tissue structures which are tighter, which may be my adductor magnus muscles fascia. It may be medial hamstring. I need to recruit the right kind of muscles. I need to reset my neural firing, which has a feed-forward mechanism where the stabilizers are recruited before that. For that, I have to do the right kind of exercises. So once I realign the joint, I balance the structures, I'm 100% sure I'm not only going to treat some of the patients with early to moderate osteoarthritis, but in many patients, we have been trying to eliminate the chances of getting osteoarthritis later. So I jokingly say to my patient, your knees cost you 3 lakhs and they are not even as good as the original ones. A car tire only costs you about 3,000 rupees, so or 4,000 rupees. So you go and get your car tire wheels aligned when they are even normal, but nobody comes without pain to get the knees aligned. But if we correct the alignments, we restore the myofascial elements before they develop, we can prevent a lot of osteoarthritis. And I have seen in my care for the last 22 years, when we are working, we have a better outcome in terms of the normal population statistics of having less osteoarthritis developing in the patients. And those who came to us about 8 to 10 years before with some early changes, they have not only improved their function, but they have not deteriorated. I don't want to put some individual patient messages, but we have recorded to a patient who could hardly walk for 50 meters and advised surgery is walking even 2 to 3 kilometers. So the right things when done in the right way definitely are going to change the way things have been happening. We are going to not only prevent surgeries, but save a lot of dysfunction and problems in the patient. That's my belief. The magic is not in an instant cure, but thinking of the long-term health. That's what Corona has taught to us. I may be a little different in my beliefs, but this is what I've been practicing and getting very good results. And that is why I wanted to share these little bits of information. I'm sorry, there was total mismanagement. I was almost sweating half an hour back because my computer had some major issues with internet surfing. So thanks to the organizers, I could be here. And thank you very much for giving a patient hearing to me. Thank you.
Thank you very much, sir. It's a really wonderful session, sir. Thank you once again, sir. Meanwhile, if you have any clarifications or questions, you can type on the chat box so we can ask our sir. Hi, if you have any doubts, please use the chat box and you can ask questions. Okay, okay. Thank you once again. Thank you very much, sir. So we'll move to the next session. Um, uh,
He is also an advisory board member of the Indian Clinical Research Association. Finally, Mr. Bhaskar Reddy, Senior Specialist Physiotherapist at King Khalid Hospital, Ministry of Health, Saudi Arabia, will conduct a case discussion on evidence-based management of knee osteoarthritis. Mr. Reddy is the Chief Instructor for Physio Foundation, India, Physiotherapy Practitioner Association, Physio Health Institution, and Health Physio Academy, India. He is the director at New Hope Advanced Stroke and Spine Rehab Care. He is an editorial board member of the Journal of Physiotherapy and Research. He is also an advisory board member of the Indian Clinical Research Association, International Health and Fitness Association, Indian Academy of Dry Needling, and Global Research Medical and Health Association. I kindly request Mr. Reddy to start the case discussion on evidence-based management of knee osteoarthritis.
Hi, thank you. Hi, not good morning, good afternoon, not good evening, good night. It is my last session, so hope everyone will enjoy. And I will not take much time so that you can go for sleep. So I would like to thank Sri Lankan Society of Physiotherapy providing me opportunity to share my knowledge. I'm Bhaskar Reddy, Senior Specialist working for Ministry of Health, Saudi Arabia, and Vice President Physio Foundation of India and Director New Hope. So we would like to go ahead with the today's session, evidence-based practice, especially on ONE, how taping will be effective, especially elastic taping. So I will show practical demonstration and my patient's scenario and how you can go ahead. My voice is audible.
yes, sir.
Yes,
It
sir.
was audible
Yeah.
and the screen was visible, sir.
Yeah, thank you. This is a small introduction about me. And I would like to speak about evidence-based role of taping in physiotherapy. This evidence-based is very important, not only, especially I mean to say physiotherapy or any area, evidence-based is very important, especially developing countries has to follow and practice evidence-based. What is evidence? If you are giving any treatment to patient, the patient can ask you why you have giving this type of treatment. So you have to justify and with proper evidence. So even when you treat any patient, like it will be useful for you for presentation, like before treatment and after treatment. It will be helpful for research. So whatever telling this treatment is effective, this treatment is effective, by saying rather than oral, you have to prove it. How you can prove? If you have any evidence, you can prove it. So this is about knee joint. As almost of our great speakers have spoken about osteoarthritis, especially of anatomy and other thing. So I will not disturb you people regarding speaking once again anatomy. So these are all pictures. So I will speak about the taping. There are different n number of types of taping is there, like rigid taping, elastic taping, which is normally called K-tape, and one more thing, dynamic taping. So in this, there are different varieties of names as they develop, like Mecanals, Monigal, Mulligan. This Mecanal and Mulligan will be like rigid taping, and sports taping, Kinesio will be like elastic taping. What is the difference means? In rigid tape, you cannot stretch the tape. In elastic taping, you can stretch the tape. In elastic also, K-tape, you can be stretching in one direction. In dynamic tape, you can stretch in different directions. So this is one of my patient. This was developed by Kenyo Case. Actually, this type of technique, which was developed especially in sports conditions for Olympics, later on it has been extensive, vast over the clinical conditions from pedia to geriatric. N number of orthopedic, neuro, pediatric, sports, gynec, they have n number of scope. And especially indications, in which conditions you can be using this taping. You can use from pedia to geria and different varieties as I spoke. So you have to keep as indications and contraindications. Contraindications, you have to check for any allergy and skin cancer or open wounds. You should be cautious when you are applying, especially for elder and pediatric cases. As you are speaking about today, the World Physiotherapy Day regarding knee joint. So what are the functions of knee joint? Same, your taping also will be provided, like support, protection, stabilization, proprioception, loading and unloading, facilitation, inhibition. So keep in mind, this taping will be helping you treat the pain so that patient can mobile. He can do his ADL activities. So always rehabilitation and exercise is very important. Okay. How it acts on body? As we have receptors around the skin. Okay. When you touch, you will be initiating the receptors. When we are applying the tape over the skin, it will be providing like a wavy pattern, which helps to stimulate the receptors, which will be carrying the pain. So depend upon how you are applying the taping over the skin will helps to reduce pain, to reduce swelling, and to improve muscle power. If tone is there, hypertone, you can decrease. If hypotone, you can initiate to increase tone. So there are different varieties of techniques. So we'll be showing how it is acting on body. Okay. So before that, fascia is very important, because after skin, no, when you are going the muscle, the fascia will be there. The fascia will be total all around the body. So the taping will helps works on fascia, so that if you see this video, you will be knowing how fascia is acting. So you can see this one.
నా ప్లేస్ లో నేను
So hope this video helps you. How fascia is very important, how taping. As I have shown this video, now you can see when tissue, any injury or pain or swelling, any condition, you can see in first slide how the tissue is there. After application, here you can see wavy pattern. So it will provide, it will act over the limb, fascia, muscle. Okay, you can see the capillaries before injury, I mean to say during injury. After application of tape, you can see the difference. Proprioceptor, how it will be activated, capillaries and lymphatic vessels. And there are 4 types of techniques are there. It's like a muscle technique, ligament technique, correction technique, lymphatic techniques. I will be showing the combination of muscle technique with ligament technique for osteoarthritis, how to treat. There will be stretches. As per American, there will be, you have to stretch the tape maximum. In European type of taping, the stretch will be less. You will be stretching the muscle. And you can see the clinical implications, why you have to use the taping and pro and cons. So this is actually, this is a new recent treatment. So many research is going on. So we have most of the studies they have conducted in normal. So now there are many studies who are doing masters and PhD they are doing on elastic taping. So there will be more research will be coming. So we can go ahead with what are the rules. Here you can see different shapes like I, V, X, lymph type. So you have seen the picture over the knee joint. There are different varieties of cuttings are there. When you are selecting the joint, you have to use this one. So as I spoke, the evidence regarding research is very important. There are different, because in research you have to take as a meta-analysis. So which will be level 4 evidence. So these are all the things I would like to show you for the research. And this is one of my patient who is bedridden, 80 years, female. She has CVA, osteoarthritis, and different multi-organ issues. So she was bedridden. We treated her with physiotherapy, and to enhance, to decrease her pain for instant, I have used a K-tape, stimulating like same time muscle. Then same time I'm protecting her patella. So this is one of the technique which I will be showing now. So this is one more patient who have underwent different knee injuries. He had meniscal, ACL with PCL grade 3 injury. Actually, this case was advised for surgery. And you have to see, you have to ask the patient, what is his goal? If you would like to carry on like games, so then he has to undergo for surgery. He told he will be just going for office on bike. So he told he need not want to go for surgery. That time we have chosen this type of lymphatic taping technique, which helps him to fast recovery to decrease swelling. So we avoided the surgery for this case. And I am telling one more time, whatever the type of treatment you are choosing, the evidence you are giving for the patient, keep in mind rehabilitation is very important. If you are not teaching the patient with proper exercise rehabilitation program, he will come back. So it is very important, you people, as a physiotherapist, you will be proud, because many of the patients, whatever they have issues related to pain, their ADL activities, physio plays very important role. So it is very crucial point. Okay. I would like to thank Physio Foundation of India, my thing, and TMAX State. Special thanks to Sri Lankan Society of Physiotherapy, and especially Mr. Dr. Vasant, and his core committee, organizing committee, and his team members. Within short span of time, they made this world webinar all around the globe. I would like to thank them. And this is my contact details. You try to note my Saudi WhatsApp number. If you would like to go for any abroad countries, you would like to study material, what is the scope for physiotherapy? If you have any doubts, you can contact me through my Saudi number. Before that, I would like to show, is my video is visible?
Not yet, sir. We can only
Not
see the presentation.
only presentation. Okay. Now you can see, no? As I told, no, this is the elastic tape. There will be different colors. So this is the tape, what I told, rigid tape. You can see, you cannot stretch this tape. This I'm told K-tape or elastic taping. You can tear like a paper. You can see here the wavy pattern. When you apply over the skin, it will provide a wavy pattern over the skin. Okay. This is a stretch I told. Elastic taping, you can stretch in only one direction. You cannot stretch. This is the K-tape, I mean dynamic tape I told. This is dynamic tape. You can stretch in different directions. You can see here. I can stretch this way. I can stretch this way. Okay. You can stretch in different directions. Both principles are different. And there will be pre-cut tapes will be there. Already ready-made tapes will be there. Previously, I spoke regarding different shapes. This is like I shape, like V shape. Okay. And this is multicolor tapes. There is some special test also to conduct which type of color will be suits for you. And this tape, different colors. These different colors are there for especially females for their dress matching. So nothing to worry, whatever the tape you have, you can treat them. Now I will show you the knee joint thing. One more important thing, especially during COVID, infection control. It is very important for all physios. This alcoholic rub. Okay, you have to take and you have to remove ring or watch anything. Just apply over the hand and right hand over left hand over right hand, then here, then right over the left like this, then like this, then thumb. You can finish in 30 seconds. So when you are choosing a knee joint, especially osteoarthritis, whatever it's like stage 1, stage 2, stage 3, even patient bedridden, you can choose this technique which helps to decrease pain. You just select the knee joint. You have to take the measurement, the tape in resting position. Okay, just see. So this is the knee joint. So you have to take this one as a base. So you can see up to where you would like to go for quadriceps, VMO. So you can use this one. Just I have taken the tape, I measured. Just you have to cut it. Keep in mind, if especially for male, the hairy thing, you have to trim the hair. Okay, then only you can apply. Otherwise, when you are removing, it will be very difficult. And also same time when you are, it will not stick properly. So important thing, when you after cutting the tape, you have to cut the edges. If you are not cutting the edges properly, the tape will come out easily. So this is waterproof. They can take shower. Most of the patients, they will think expensive, it will come out. They will not take shower. Tell them to take shower. Tell them to not apply soap over the tape. After shower, tell them to press with the towel. Okay. If edges will come, tell them to cut the edge, not to totally remove the tape. Okay. So here, this one. Okay. Then I choose this one base. Then I will be selecting. Here I will be showing muzzle technique and ligament technique. If you want to cut the tape middle, you just hold it like this, so it will come equal. Okay. Just cut the tape. So don't cut the, you just go up to the base. Okay. Here you just tear it. Here also you have to trim the edges, otherwise it will come very easily. Cutting edges is very important. Okay. Just first, when you are applying the base, just neutral position, apply the base. I will show 1 minute. So because it is very important, so just see the patella. Okay, base of the patella, just tear it, it will come very easily. Just don't touch the glue. Most of the YouTube videos, they will touch the glue. Don't touch the glue. It may, if your hand is infected, you are giving infection to the patient. If patient is infected, you will be having problem. So that's the reason I have shown you alkalic rub. Just neutral position, just apply the base below base of patella, just apply the tape. You have to trim the hair, okay, before application. And same hand, this alkalic rub, you have to prepare the skin. So tell them to wash the legs and make it dry, then apply alkalic rub over here, make it dry. Okay, so I applied my base, then I will tell the patient to fold a knee. Then you can see this one, just pull it like this, just hold here, then here just little stretch up, cover over the patella. This is the ligament technique I am applying here. Okay, from here I am going for muzzle technique. See, now I will be applying without stretch over quadriceps muscle, bulk of the muscle. Okay, then here next strip, just same, pull it little, so the cover will come. Okay, here just hold it, just pull little up, apply little stretch, cover the, here cover the patella. Okay, after here no stretch. Then after application, you have to make it hot. So just rub over it, so the glue will be activated and attached. Okay, see, when you will tell the patient do isometrics or isokinetic, whatever the exercises, it will help to initiate the bulk. It will be activating. So if you are doing the exercise one time, it will be more, it will be equal to 5 to 10 times. And also you people, sometimes you will be advising kneecap. So for this, when you apply, it will be acting like it will protecting the patella. It will not shift like medial or lateral. So no need any kneecap. It will be activating the muscle, same time it will be support. That's the reason I told functions of taping. It will be supporting, it will be reinforcing, it will be offloading. Okay, so now you can see when I will stand now. So here you can see here the muscle. If you see properly, here you can see wrinkles. So it will be initiating the quadriceps muscle. Okay, this is very important. If you applied the tape properly, muscle technique, you can see these wrinkles. Okay, This is very important. So before and after treatment, you can ask the patient VAS scale. Okay, you can check it. And removing also is very important. Okay. So how to remove? Just you apply this alcohol hand rub. Okay. When you just lift, so keep your finger, push it. So there will not be any pain. Okay. Otherwise, it will be pain to the patient. Okay. Same thing here. Just you can remove it. So hope everyone got my presentation. I'm sorry for the delay, and hopefully all the participants, physios, professionals around the globe, I would like to thank once again Sri Lankan Society of Physiotherapy making this event went smoothly. And I will share once again my screen. So if you have any doubts, you can ask me.
Sir, there are a few questions. Shall I read it, sir?
Yeah.
The first question is, sir, can a plastic tape be used instead of rigid kinesio tape? What is the difference between TheraBand and kinesio tape?
Can a plaster tape be used in lieu of a rigid kinesio tape? What is the difference between TheraBand and kinesio tape? Yeah, actually plaster tape. I brought many tapes. I have a number of tapes here. One more is there, plastic also. This one only the thing. Why this rigid tape? Initially we are using. My video is visible.
Yes, sir.
Yeah.
Yeah, you can see this is a rigid tape. This rigid tape you cannot stretch, and it will be like a zinc will be there, and it will be allergic to the patient. When you apply not only this tape, you apply any tape over the skin. So after more than 24 hours, you cannot have this rigid tape. You will feel something is there over the skin. What is the difference? This elastic tape, when you apply over the skin, after some time you will not feel anything, because that is the difference. And this is waterproof, so if you take shower also, there will not be no issue. So that's the reason I suggest to use elastic taping. You can use any type of tape. Main thing, you have to take care of patient skin. When he will come next day with blister, that is you are adding one more problem to him. So you should be very careful. And before electrotherapy, how you are testing on yourself, you have to check the tape on your skin. You have to check the tape over the patient's skin. If he came today, you take assessment, you just apply piece of tape over the skin to the patient. Tell him to come tomorrow. Just to see for any skin allergy, any allergic reactions. That is very important. Next question, sir.
The next question is, what do the different colors of kinesio tape means?
Yeah, this is very important question. Actually, one subject should be there. So I would like to show, as I said, no, there are different types of colors. So we will be checking like O test. We will be keeping I mean to say, if patient having right hand dominant, whichever the dominant side, you have to keep the tape. You have to give the tape one color, and non-dominant head, you have to give one more color. So before giving, tell the patient to close his eyes, give the tape, and try to feel the tape, and we will be giving the resistance. Okay. In modification, there is one test is there. I will explain you very simple. You ask the patient dominant side, which is right or left. Ask the patient close his eyes. You just give one color tape. Just assume that I will giving green color, but you will, patient will be closing his eyes, and you will be holding this one. You will be giving the tape, and you will give resistance for elbow flexion. So after, you can tell him to feel the resistance. Later you give another color, tell him to repeat the same test. Most of the people, they will feel the difference. Even though the color, the weight of the tape, everything is same, but as per our psychological, there will be some people, they will feel this color tape I will feel light. This tape, I have shown one more tape. No, this I will feel heavy. So when you want to give like a sports training, you have to choose the heavy tape which he feels for strengthening training. If he will feel like you want to decrease, or for hypotone, you have to use light weighted thing. That is the only difference. And another research, they will be saying that what I choose most of the cases, especially females, they will be asking, today one patient I treated with this color, they will be asking same color. If they have issue, they will come back, doctor, that day you have given me green color, can you please give me green color? You have to explain them, there is nothing in the color, you have to choose what is the exact problem. You have to treat the root cause. So you have to explain them, because if you are not explaining, people in psychological, in brain, what it will think, doctor applied today this tape, now he applied is another color, maybe the effect, even though there is effect, he will not feel it. When he will come back, he will tell no. That's the reason. This is a simple test we will be showing during our K-tape courses. And whatever tape available with you, you just treat with the tape. No need to select any color. This is my experience. Next, sir.
How long can you leave Kindshare tape on?
Yeah, this is a very good question. As I show now, this is a rigid tape. We will be keeping maximum 24 hours to 48 hours. This one, elastic tape, you can keep it minimum 3 to 4, normally even 7 days you can keep over the skin. Unless until if you have any itching or irritation issues, you have to check it. Otherwise, it's a pure cotton, non-allergic. Okay.
Okay, the next question is, which one is better for offload the muscle, dynamic or Kindshare tape?
As holistic approach, we have to use, I will be using, depend upon the sports. If I am treating a sports condition, I will be I want some joint, there should not be any movement. For that, I will be applying this rigid tape. Same time, I will be using this elastic taping, which I would like to have little movement, and same time to decrease pain. Dynamic tape, we will be using combination. That's the reason holistic approach. You have to choose what is the problem and what patient is expecting from you. He want to decrease pain, or he wants strengthening, he want to increase his tone, or he want to decrease the tone. So that is important, depend upon the patient choice. We have to choose our tape, which type of tape will be suitable for this patient.
The next question, sir, will it provide the same effect if we use an elastic blast tape when the Kindshare tape is not available?
Same effect. See, the main effect I told, no, this elastic taping, actually it will provide like the wavy pattern, because here you can see the wavy pattern. So this helps when you attach over the skin, no? So it will stimulate the receptors. But when you apply another tape, even though as you applied over the skin, it will try to start, but rather than decreasing pain, you will feel some difficulty, nociceptic. Maybe there will be chance to increase pain, or there will be chance for blister or allergic. My request is, if you don't have any tape, just leave it. You just work on your hands, like myofascial release or active release techniques. So try to use that one if you have. And also, if you have tape, elastic tape, don't apply over the skin. As I told, no, you have to prepare the skin, you have to check for the allergy, you have to test it, then only you can apply the tape over the skin.
Then the next question is, how many days we should apply K-tape for osteoarthritis knee patient, and how long K-tape should be there on a knee in a day?
See, as I told, no, this elastic tape, K-tape, you can keep it for even 4 to 7 days. And when you apply over the knee joint, you just leave it. Nothing. As I told, no, when you apply over the skin, after some time, you will not feel there is something over your skin. So that is the reason, when you apply over the knee joint, tell the patient main concern, my concern to the patient. If have any allergic or itching issues, they has to contact you. Otherwise, tell them leave it, do your activities. And main command you have to give to the patient, they has to do exercises. Why patient is not doing osteoarthritis Q exercises? They will be telling pain. When you apply this tape, no, it helps to decrease the pain, it will improve circulation, so his pain is eased. So tell him to start the exercises the day one when you apply the tape.
The next question, sir, how much stretch for ligament taping?
Yeah, ligament tape, like it's like, I will show you here. So assume this is the tape. If you stretch the tape, no, this is the 100%. For ligament technique, we will be stretching 50 to 80% stretch. This is 100%. When you remove 50, this is no stretch. Even when the tape over this paper, there will be minimum 10 to 15% already stretch will be there. That's the reason I told you it's a vast syllabus. We cannot complete within some hours. So as I am telling, no, this stretch, there is two concepts is there, American and European. American, they will be telling stretch more tape. In European concept, stretch the muscle. That is very important. If some patients, they cannot stretch, I mean the patient cannot stand or walk, bedridden, that time you stretch the tape. When patient able to move, then you don't stretch more tape, you try to stretch the muscle.
Okay, so the final question, sir, which kind of tape can be applied for facial palsy patient?
Yeah, facial palsy, you have to see main thing, facial palsy or Bell's palsy, that is important, because lower motor, upper motor, main thing we have to see the root cause. It's because of carcinoma or fracture or anything, we have to see. What one of my student who attended the course, she is BPT, she done her internship program on Bell's palsy K-taping without doing any stimulation. I mean to say, comparative studies she have done, it's a nice topic. You have to see the patient Bell's palsy, you have to, there will be always compression due to cold or ear infection, anything. So this blockage will be there. For blockage, you have to open here. So I will be using muzzle technique here. Same time, as I told, no, there will be many techniques like correction technique is there because facial deviation is there. It will go like this. You have to correct with normal taping. We are using plaster, no? So we will be applying. And one more tape to close eye. There are in Bell's palsy, we are taking as a advanced course. So in this advanced course, we are showing there will be 2-3 varieties are there. One technique like these 3 areas like over, I mean to say above eye, over the nose and lower jaw. We will be applying one type of tape and muzzle technique here. And another technique for correction technique we will be using.
Thank you very much, sir. It was very useful and knowledgeable, sir. Thank you very much for sharing your knowledge with us. Thank you.
Thank you. Thank you all.
Thank you so much.
If you have any doubts, you can contact me through my Saudi WhatsApp number. I will be there to help, and I'm so happy thanks to Sri Lankan Society of Physiotherapy. Many of physios, especially India, this time late night around 11 o'clock, still people are there to listen presentation. I'm so happy. I would like to thank one and all. I'm happy to see my friends like Jamin Bhatt and Mustafa. I'm so happy to see Manish Arora sir and great dignitaries around the globe.
We are reaching the end of our session now. It's time for word of thanks. I cordially invite Mr. Rasika Jayakodi, the Honorary Secretary of the Sri Lanka Society of Physiotherapy, to deliver word of thanks.
Ladies and gentlemen, it gives me a great pleasure to make this vote of thanks on behalf of the Sri Lanka Society of Physiotherapy, to extend my hearty thanks to the individuals and organizations that help us make this event success. Above all, I am thankful to our panel of lecturers who made a marvelous contribution by accepting our invitation within a short time. You shed a light today on the topic osteoarthritis in an excellent manner, allowing us to have a better view of treatment. Next, I would like to extend my thanks to the organizing committee that put all their effort to make this event successful. Next, it is my duty to extend my sincere gratitude to the World Physiotherapy, the physiotherapy societies and associations for their fullest cooperation extended towards the success of this event. Also, I take this opportunity to thanks to our generous sponsor CIC Holdings Sri Lanka, who came forward to help us during this crisis situation. And special thanks go to Mr. Jagat Bandara, who helped us by sitting behind the screen. Last but not the least, it is my utmost duty to extend heartiest thanks to the participants who made their valuable contribution by participating in today's webinar. Long live the solidity of the physiotherapists around the world. Thank you.
Thank you, Mr. Jayakodi, for thanking everyone on behalf of the society and shouldering the burden of bringing this event to a successful conclusion. So, we have come to the end of this webinar. Thank you all for joining us to celebrate World Physiotherapy Day 2022. We hope you have learned and enjoyed the session. Goodbye for now.
Thank you.